Yesterday, I know many of you were here. Adriana, we had about 400-ish, and we expect 500-600-ish through today as the Congress, the main body starts. Of course, we had yesterday a Global Clinical Engineering Summit, our 5th one, setting priorities for the next couple of years, looking backwards, looking forwards mostly. But there's been a lot of progress, and certainly a lot of progress working with you, Adriana. And then we had 4 short courses on high priority topics for clinical engineers around the world. A delightful lunch at the Expo Center, which we inaugurated, opened for the first time. And then we had the GCEA, Yadin, I know you're online somewhere, the Global Clinical Engineering Alliance annual meeting, many members, many others in the midst of joining, really a focus on national society and alliances with many stakeholders around the world to improve patient outcomes and to improve the lives of patients, which is a theme that's always on Adriana's heart. So I'm here representing certainly the Global Clinical Engineering Alliance, but also Fabiola Martinez, who's in the bus on the way over, the chair of IFMBE Clinical Engineering Division, CED, and the incredibly able brother of mine, Jatendra Sharma from Amtz, welcoming you this morning. And more friends are coming in, that's great. But our privilege this morning is to hear from Adriana Velázquez in Geneva, Switzerland. I met her in 1991. She was the star student, big surprise, of one of our early programs. And we've all cheered as she's, and you know, if you knew Adriana, she would say it's way not about her, it's about the patient. And we want to give her the mic in here in just a moment, but she had done her undergraduate in Mexico City, of course, in biomedical engineering, a master's in Case Western in the US. A dozen years after I met her, she started Center for Health Technology in Mexico, Cenatec. In 2004, she was number 3 in the Ministry of Health there as a clinical engineer, groundbreaking. In 2008, I think, came to Geneva and assumed her present role as the head of the medical device unit of WHO in 2009. So I think 15 years, though, in Geneva. We celebrated her anniversary recently, and it's a privilege to bring Adriana to you this morning. Dear Adriana.
Thank you very much, Tom. Okay. First of all, it's really an honor for me to be with you, even online. I am really honored for this event. Okay, now let me tell you the story. Exactly like Tom was saying, and we didn't agree on these words before, but yeah, actually I met Tom and the Dean and others in 1991 in a clinical engineering workshop in the USA, and then many things have happened so far. Then 2010 was the first global forum on medical devices in Thailand. Then 2015 we met for the first time at the Clinical Engineering Health Technology Management Conference in China. Then 2018, we were there. We were there exactly where you are in Visakhapatnam, and I really want to thank Jitendra that hosted us for the 4th Global Forum on Medical Devices. And now this is the venue for the 2023 5th International Conference. So I just wanted to say that I'm really sorry I cannot be with you, but exactly what Tom was saying, patients go first. And these days, the patient was my husband. He suffered a cardiac infarct 10 days ago, so then I had to cancel my travel. Luckily not, but also thanks to God, thanks to the healthcare workers, and thanks to our medical technology. He is stable, he's doing well, and we're glad that he's now recovering. So I just want to apologize for all people that I would have loved to see physically and talk and chat with all of you, Yeah, patient go first, and in this case it was my own family, and I just pray for all patients that can recover quickly, that can have the technology they need to be diagnosed early and to be treated. So, let me go to the next slide. Okay, so first of all, why is our work important? And secondly, what tools have been developed by WHO? But they were mostly developed with you and for every student, every professional interested. And then I'll give 4 take-home messages. So number 1, why is our work important? Exactly what Tom was saying and what happened to me now is because we support patient care by ensuring that technology is safe and working properly to protect, diagnose, or treat patients. And this especially is important during the pandemics, during war, disasters, but also in peacetime. And it is so that we can ensure that there is universal coverage. And as you know, there are many components. The healthcare workforce, the infrastructure, the medicines, and the medical technologies. We need everything together to work well. And that is exactly our goal. So I just took a snapshot of the WHO website this morning, like a few hours ago. So this is the world today. We have the conflict in Israel and the occupied Palestinian territory. We have the World Diabetes Day in 2 days. We have the World Pneumonia Day tomorrow. We have the Cervical Cancer Elimination Day of Action in 17 November. And then we have infections, disease spread in Gaza, earthquakes in Afghanistan, and dengue in Chad. And for all of them, medical devices are indispensable. So they are indispensable in emergencies, non-communicable diseases, to manage non-communicable diseases, to manage infectious diseases. So we are an important part of the healthcare provision, and we need to be present, we as clinical engineers, but also we need to ensure that that technology needs to be available, safe and effective, and of good quality, affordable and appropriate. Our work includes the selection, the assessment, the management of medical devices that will support local, regional, and global healthcare to support patients everywhere. So here you have different images, and let's think about them. Exactly what I've been insisting all the time. It's not about the technology, it's about the patient. How can that technology bring something good for the patient and for the health workforce that can help diagnose properly? There's a huge trust. So there's trust. You trust that the equipment works. When my husband was suffering, I trusted that the equipment was working, that the monitors were doing the right diagnostics, that the medical doctors can have the technology available to treat the patient the seconds they have to do it, because every second counts, talking about the emergencies. So now, let's go to the next stage. What tools have been developed by WHO with you and for every student and professional needed? And I really want to say with you and for you, because many clinical engineers all around the world has been helping all the work that WHO has been doing in the past. So first of all, we have to consider that some of us as clinical engineers, we were looking only at the medical equipment. And the medical equipment, remember, that is just one of many types of medical devices. And now many more software applications are coming. We have to also be sure about the single-use medical devices and the waste management of those devices, the biocompatibility of those devices, the surgical instruments. We're now working with surgeons, actually from India, to define the list of surgical instruments that are needed for many healthcare interventions. We also have all the areas of implantable medical devices with the hip prosthesis, with pacemakers, with many others. But also a huge area on everything related to in vitro diagnostics, all laboratory equipment. And that is not always considered by all the clinical engineers, but that's absolutely core and indispensable element of the medical devices. And as you know from many of the presentations that we made before, is we have to have a process to ensure improved access to safe medical devices of good quality. So we have the 4 sections. The first one is on industry and academics. The second is on health technology assessment, and that is really the selection of medical devices for reimbursement or procurement, be it by the hospital or by national health services. The regulations, we need to work very close to the regulatory authorities to ensure that they have good products marketed in every country. And then all the health technology management piece on the procurement, we have to include donations there, the installation, the training, the maintenance, the cost, operating costs, clinical effectiveness, up to the commissioning and replacement. And we have to work together with all the other teams too. Something that is very important is we might have clinical engineers in all these different 4 different sections, and we need to talk with each other. It is very important that at every country there's the communication, harmonization, standardization of all the processes between them. And we have something that goes all along, that's the nomenclature, that's the name of the devices that we will be using for the procurement, for the installation, for the assessment, etc. So these are like the 4 elements. And as you remember, these are the WHO frame of colors: the blue, the green for regulations, the pink for assessment, and the red, orange for research and development. And then the medical devices series was started in 2010, and then we developed many of these documents. So we started with the development of medical devices policies, the Global Atlas, the Human Resources for Health that was published in 2017, and then we published the book on regulations 2017, health technology assessment, needs assessment, donations, maintenance, and so they were all done in 2011. Then we started with the list of priority medical devices and essential vitro diagnostics. But many of these that were done in 2010, we are actually now updating them so that we can keep with the trends. As you all know, the availability of biomedical engineering was a major amount of work that we did with the help of ICEHTMC and many biomedical and clinical engineers around the world. And I think it would be a good time to start updating this document, because now we have many more biomedical engineering societies, so clinical engineering groups, even you as the global one, and many others. In WHO, the first thing when I arrived, that was 2008, we launched the baseline country survey on medical devices. We wanted to know what was happening in every country, who has a policy, who has a regulatory authority, who has an HTA agency, which country has health technology management. And this document was latest updated in December 2022, and so the publications are ready. And they include the profile, the country profiles. And let me show here, we have Argentina, but they have the country indicators, they have the national list of medical devices. But you can go there, you can click in here, and you will find the information from every country for everything of these different topics. And then you have a list of comments. And this list of comments, if you open the annex, you will find the things that were submitted by the ministries of health for each of them. And then you have the contacts and names of the person. So we hope that this can be useful for all of you. Then, as you know, that we have developed this health technology assessment, management, and priority medical devices list. The 28 books are being updated. That is the health technology assessment. We're starting the update now in November 2023. The medical devices group on donations was started to be updated 2 years ago, but then with COVID, and now we will be updating it. And I hope you can all have a very final draft by December this year. We have made a lot of help. And now it's much more linked with the regulations. So the idea is that whenever a donated device gets into the country, it will have to be approved by the regulatory agency, not going through the back door, and then we were having many wrong donations. And this does not only apply to low-income settings, but also even high-resource countries. The book on maintenance, CMMS, and the inventory is being now also operated by another team that will be a collaborating center for WHO hopefully in the future. So many things are ongoing as you see, and now we have here the priority medical devices, which I will explain here. So we have two main products in WHO. There is the essential medicines list that has been out for the last 50 years. So now in 2017 and 2015 and 2018, we started with the selection of the WHO model list of essential in vitro diagnostics and the priority medical devices. This is a subset of this one, but it includes other information because in vitro diagnostics has a specific regulation, specific targets, specific things that do not apply absolutely for all types of medical devices. So this list has a different expert group than the one that developed this list. But here in the priority medical devices, we include all kinds of medical devices, as you can see in the images below. So here are the list of priority medical devices that we have developed for reproductive maternal newborn and temperature, for cancer, for COVID, for cardiovascular and diabetes, and then the model list for essential in vitro diagnostics. And then we have been developing also technical specifications with the help of many of you, which have to ensure better procurement and better quality. The WHO list of priority medical devices are all based on evidence. So here we have to go through the clinical guidelines, then review the interventions, then decide what medical devices are needed for each intervention, define the priority list, and then we publish it, and then we go to a database. As we can see in this image, all these medical devices have to be there, and they are listed one by one with its specifications. Also the priority list, it is divided by levels of care. So if you go into the books, you will find which ones are needed at primary healthcare level, which ones are needed at pre-hospital emergency care, like the situation that we had with my husband. There was an ambulance, so there was, and you know, stroke or cardiac infarct, or they can happen anywhere, or trauma. So we have the pre-hospital emergency care, and we also have it like for war and pandemics. Then we have the primary care, secondary care, and tertiary care, and everything is divided by the type of area of work. So this is an electronic data system. It is called Priority Medical Devices Information System. MED, there, and I is the information basis for the system. But we've been updating it, and now besides those books, now we have a book of package of eye care interventions, trauma and emergency surgery kit, and we have added all the priority medical devices that were developed by the PAHO office, and we will be updating here. Yesterday we had a meeting with the oral health team, so you will see the continuous expansion of the list of priority medical devices. And here, as you can see here, and this was taken early this morning because just for you, we had the latest release that was done overnight. And we hope that if you go to the list today, you will find a more updated version that we had also yesterday, but in the last 3 months. So here you can go and check for all kinds of monitors, all kinds of devices. You have the service delivery platforms, who is the user, the kind of patient, the year of the patient, etc. And we also have all the list for all the publications. So in the list, what we did is we put it inside all the priority medical devices with all the guidelines that we have, and so that you can go there and just open the different links and then find the resources. We are working also to have in the next pages, and I think Ricardo is over there, but there are many that have been helping us on the surgical sets, so, or what would be called packs, that is the packages of medical devices that are needed for every intervention. That will show it to you next year. But on the priority, on the essential in vitro diagnostic list, we have the kind of test format, the type, the equipment required, instruments range, but also the evidence of clinical usefulness and impact. And the last fourth essential in vitro diagnostic survey, I forgot to add here, was released less than a month ago. So if you search for the essential in vitro diagnostic list, you will also see the latest version. That has a structure that says which are the tests, the laboratory tests, the in vitro tests that should be done in community settings or primary health care, those that should be done in a laboratory because they require more infrastructure, but also the do not do recommendations, the ones that are not recommended by WHO. And then there's also an electronic platform, and then if you go into the list, you can also reach the essential in vitro diagnostic list, and you can also reach now the Universal Health Coverage Compendium that has a link with all the other interventions that are happening in WHO. So this is ongoing work. Now we're moving from the books and PDFs into data systems as mandated by the World Health Assembly. So here you see the new books that have been added, and here we have the books on the essential in vitro diagnostic list. And these two platforms, we will connect them in the future months. So the idea is that WHO found the evidence, WHO has the list of devices per delivery platform or by for an emergency room or for an operating room or for an angiography room or for intensive care or a laboratory, and then the countries can take these lists, or you can take this list, can extract from this what you need depending on your resources, the epidemiology, what you need, and then it is the country with you as experts to decide the planning where should each of these medical devices go in which level. So now let me tell you that this year there were very important resolutions in the World Health Assembly. So one of them was about diagnostics. And for diagnostics, we don't only call the ones in vitro and laboratory, but all kinds of diagnostics. So it's anything, any device that will help us screen, monitoring, prediction, staging, surveillance of disease or health conditions, or determination of physiological, and includes both in vitro and non-in vitro. And in this case, and I just put it as a tip here, we all should use the diagnostic medical devices, even for ourselves, for our family members, and for everybody. We need to measure our risk. We need to use these tools because remember, without diagnostics, medicine is blind. Remember that diagnostics are like the ears and the eyes of medicine. So that tells you what happens, what could happen, and so we can prevent various diseases. So I would suggest that when you go back home, you measure your risk, your blood pressure measurement. You have to keep being healthy. Do your cancer test or glucose test, the oxygen saturation, and then know your vitals and act on them and stay healthy. Okay. Another area that we work very much in WHO is the search for innovative technologies for low resource settings. Now, please remember that the low resource settings, we don't mean low-income countries. A low resource setting can be the Northern Territories in Canada or an island in the Pacific or any place where there's a disaster zone or like war that we're having now or the pandemic. So these are technologies that could work without having high levels of infrastructure settings or healthcare workforce. And the Global Clinical Engineering Alliance helped us last year to develop the framework for the areas of health technology management for indicators, and they're all of you that have been duly acknowledged in this. And now we will be releasing the 2023, that is basically for non-communicable disease. So now let me give you some take-home messages, which I hope you will remember. So first of all, we have to keep an ethical and professional attitude. It doesn't matter if we work in a hospital or in the Ministry of Health like I was
Go
doing,
first,
or
recap
in
anything you want
WHO,
from yesterday,
what
do
we're at
greetings, and then
now.
I'll come up
So
and
we have to be humble, learn absolutely every day because there's always something important that you can learn every day. Collaborate with all colleagues because we cannot do the things together. We should not do the things alone. Listen to all the final users, being the patient or the healthcare workers. Be honest and transparent, always and forever. Keep striving, don't give up. Secondly, be a source of truthful data. So search for information in the WHO website, MLAs, EDL, search for the latest WHO publications on medical devices, search for the latest truthful evidence for clinical management, and support the collaboration with ministries of health and NGOs. Third, for the nomenclature of medical devices, which I may say that in 2018, there where you are in Amtz, we presented the first draft of the new nomenclature of medical devices, which was not accepted by member states. So we had to go back and define which is the nomenclature that we can use. And the suggestion is to use the European Medical Device Nomenclature, GMPN and UMDNS. And please, please, please support country harmonization and do not develop any other nomenclature. We know we have to stick on that and work towards standardization of the nomenclature. This is really a very important message. This is the resolution that was approved, and then this was discussed in the World Health Assembly this year. And we are now in Quarter 3, and we will have to report to the World Health Assembly in 2025 on the nomenclature. And then number 4, as a clinical engineer, ensure the best for the final user or patient. So, sorry. Whenever you're planning something, whenever you're procuring something, whenever you're repairing something, whenever you're training somebody to use it, do it as if it was your family member. That's the only way that we can be sure that whatever we do will be done with all our hearts and all our minds and all our knowledge. Thank you very much.
Hi, Adriana. This is Fabiola.
Hi, Fabi.
How are you doing? I know, not so good, but I really, really want to thank you to be here with us today. I know how hard it can be under the circumstances, but we always know that you are our pillar, you are our biggest support, and because of you, we are here. And we are dealing with these matters that you mentioned it, and be sure that we are doing our best to fulfill this last slice that you shared to us. So from the bottom of all of our hearts, I really want to thank you. Thank you for everything you have done to us.
Thank you to all of you, and let's keep on working together. Thank you to everyone that organized this the international conference. Really, I wish I could be with you, but a big hug to everybody. Stay well, stay healthy.
And Adriana, we know it's 5 a.m., so go get some coffee.
Thank you very much. Thank you for everything. And I'll try to join as many sessions as I can, and I'm eager to help whoever is there in your meeting. Fabi, thank you for everything, and best wishes for a very, very successful meeting.
I know we are with us right now, so thanks so much. Well, okay, so we are going to continue dealing with the tracks and the presentation of our abstracts. But before that, Tommy has an important announcement to do.
So I think many of you know movies where there's good cop and bad cop. This is good cop, representing IFMB, Clinical Engineering Division, and I'm representing GCEA, but I'm also the bad cop in a loving, sort of compassionate way, of course. Everybody pull out your program, your schedule for the day. If you have it on your device, maybe you have it in a handout from registration. It doesn't look exactly like this, but pretty close. And let's go over the schedule. You know, we start this schedule in 5 minutes. This is called just-in-time discussion. All right, so we had a welcome by GCA CED, AMTZ. Dr. Sharma's been in the room. I know he welcomes you. And as I said, Fabiola Martinez from Mexico represents as chair of the IFMB Clinical Engineering Division, and I represent the Global Clinical Engineering Alliance. So welcome. And I know some of you have had an interesting morning already, but now the fun really begins. So as we see from 10 to 12, there's tracks A1, 2, 3, and 4. They're in 4 different locations. I'm saying things you know, but I'm just going to say it again for clarity, and I'm going to say it quickly. So the one track, A1, B1, C1, will be in this room, Ampere. The second track in Omega, many of you have taken a tour of this convention center. On the other side of the building, there's another hallway. If you were to come in the front door, on the left side of the hallway, and you turn left, and you went past some monitors which are showing some of our posters, and you'd enter a hallway. On the left-hand side of that hallway is Omega Hall. It has room for about 300 people. We assigned these series of presentations somewhat randomly, but so go where you want. Maybe there'll be standing room only in some of the places. On the right down that hallway, on the left is Omega Hall. On the right, first you encounter, if you came in the front door, which you did, you'd encounter Celsius, and then a couple of doors down, you'd encounter Tesla. And those 2 halls are about 50 people, but they're very nicely air-conditioned. You'll enjoy your time there. And there's wonderful presentations in all of these halls. Now, so that's things that you already knew. If I were to look into track A1 about pandemic response, one of our 12 topics, Dr. Elliot Sloan is the chair. He's in the room. He could stand up and wave. There he is. The second one, capacity building, first one, is Dr. Manish Kohli. He's in the room over there. Here come the lights. Third is A3. So A2 would, of course, be in Omega. A1 would be in Ampere. A3 would be in Celsius. Dr. Franco Samini from Uruguay is already over in that hall. And then, once again, for the next 2 hours, I'm talking about regulation and policy. A4, Dr. Sudesh Sivarsu from South Africa, I know is around. I think he's around. So those session chairs will both start with an opening presentation, but they will also keep the 8 different speakers on track, 15 minutes each. And those of you that are part of the presentations know all this. Now, there's probably 3 different situations, but I don't want to confuse with too many words. If you have a PowerPoint and you're here and you haven't had it loaded into the computer in the room where you're going to go speak, either this morning or this afternoon, go do that right after I shut up. Go to the room, particularly those for the next 2 hours. If you have not loaded your presentation you're going to give this morning or this afternoon, go to the room right after I stop and do that, because there's several of you that haven't. Another situation is people who couldn't be here and they've sent us a video recording, and that will be teed up by our IT friends in each of those halls. And the third situation is some of you have loaded all your presentations already, and so then you can relax, but it's still time to go to those halls. In fact, I need to stop now. So I think there's probably no questions, so go enjoy the day. We'll see you this afternoon after these sessions. And you can walk between sessions. You can go hear one presentation, one room, and another. We're very relaxed around here. So, all right, Dr. Sharma. We can't hear you. Can somebody give him a mic?
The post-lunch dedication of telemedicine floor to Maria.
Thank you. We share a common brain, which is of great advantage to me because he has a very big brain. So if you look at the schedule today, this track A1 through 4 is 10 to 12. There's a short break before the next B1 through B4, and then blessedly there's some lunch at 2:15 to 3:15, and many of you were here yesterday in the exhibition hall getting lunch. In the second half of that lunch hour, in other words, 2:45 to 3:15, we're going to gather in the Pyramid building and honor our colleague Mario Castaneda from US/Colombia. There's a room named in his honor. He died October 1, 2022. So we're going to honor Mario at 2:45 in the Pyramid building, and once you get there, you'll know what to do. I think it's like the third floor. And then after that, 3:15 to 5:15, you know, I would lovingly say there's lots of programs that are very relaxed about schedule. We're not. We're going to stay on time, and it'll be fun. So go enjoy.
Okay, again, welcome. I'm Elliot Sloan, and I'm from Villanova University in the United States, and also with the Foundation for Living Wellness and Health and the PUL Alliance, as well as GCEA. And this session, A1, is going to be talking about pandemic responses and clinical engineering experiences and knowledge. And I will lead off the session with my own presentation, and then we have a very rapid set of 8 presentations. Again, as Tom said, if you're here for a 2, a 3, or a 4, you're in the wrong room. You'll have to move to one of the other conference rooms. Very good, thank you. So why don't we begin, because I want to use my time well, and get the next speakers up here. So what have we learned for low and middle income countries during the pandemic related to telemedicine? And when I use the phrase telemedicine, I really mean telemedicine and telehealth, which are terms that are intermingled in the real world, especially during the pandemic, where we had essentially a rainbow of different services done with remote care and capabilities. So during the pandemic, in the very first weeks of the pandemic, we realized at IFMBE and GCEA that there were enormous numbers of new technologies coming into the marketplace, and it was a remarkable experience in the literature, the published literature, because the pandemic inspired the publishers to release and eliminate the firewalls so that the globe could learn together. So we had a living, learning laboratory that you and I experienced, our families, our nations experienced firsthand. And the rate of publication of articles of all sorts related to COVID-19, whether it was diagnosis, treatment, AI, telemedicine, telehealth, began to flood the market. We initiated a literature search from the very first weeks, scanning the global literature, and it started with maybe hundreds of publications, and then it flowed to thousands of publications, and it became tens of thousands of publications in the peer-reviewed literature. We looked at all of the literature through the NIH PubMed and the Euromed and several other systems, as well as individual articles, as well as looking at the references in articles, which allowed serendipitous discovery. For example, here's an article related to Internet of Things that came out of Iran, and another article related to telerehabilitation services as done in Saudi Arabia. What I noticed very quickly, I became the curator, I became the librarian, And all week, every week, I scanned the literature. I read the abstracts, I read the titles, I did searches and serendipitous searches. We created a daily newsletter called Hacking COVID, and in that newsletter we had links to all of the peer review articles. So we gave the Globe access to that, and we made a repository. These are archived at a global CEA website. You have access to all of those links. We're not getting control again. All right. For example, here's an article related to Paraguay Ministry of Health. This was in the first months. Our colleague, Dr. Pedro Galvin, and I think he has a presentation here during the conference, worked with the Ministry of Health in order to prepare an AI system for screening patients and making decisions about triage. This was an aid to the physicians, aid to the Ministry of Health to allow them. In the conclusions, the use of sensitive and specific AI for stratified rapid detection of COVID-19 in patients with respiratory conditions by using chest CT scan images and a telemedicine platform in public health hospitals in Paraguay is feasible. Here's a clinical engineering colleague who is inventing technology for the globe and for his country. Next slide. Another example from the African Digital Health Project. The conclusion here was that it's called a mobile health platform using modified consolidated framework for implementation research. The value of bringing the perspectives of both end users, healthcare professionals, and patients to the table across the domains was valuable for their telehealth activities in Africa. Now, it's important to understand the global literature is very hard to penetrate. Those of you in the academic world who have tried to publish in peer-reviewed journals know that it takes a lot of time and often a network of colleagues and a prior publication record in order to get your work published. Because of the pandemic, we saw even small countries be able to access the literature and share their experiences. These are all, again, available to you in any part of the world, whether it's low, medium income, or the higher income countries. And we call the adoption of technologies for higher income countries reverse innovation, taking innovations from smaller places and making them repurposed for healthcare around the globe. Here are some examples of applications and services done by India. India has a long heritage of teleradiology, and they also not only developed AI algorithms, but did quite a bit of telehealth for their own needs. Historically, India has provided teleradiology to the United States, to Europe. Now they're providing more teleservices in India itself. Here's an article from Vietnam related to telemedical practices at one of the general hospitals. The general distinction about telehealth and telemedicine generally has been perceived as a medical practitioner to a medical practitioner diagnosis or care communication. Telehealth has been a less specific care, health, or wellness communication with the patient. However, during the pandemic, we had many cases where physicians provided direct patient care via telemethodologies. Here's another example from Vietnam, digital technologies to support patient-centered care in low and middle-income countries in the Asia-Pacific region, a scoping review. This was another fascinating part that you'll find in the archives, in the repository. Meta-reviews look at the published literature and analyze the published literature and draw conclusions from the published literature. So it's a compendium of articles related to the particular topic. It's a very powerful tool. These are things that we as researchers have had to do on our own in the past that researchers around the world have shared with each other. There are thousands and thousands of these articles in the archives. And by the way, every one that we published, we also keyworded with either telehealth, telemedicine, or telehealth and telemedicine, and also ML/AI, machine learning and AI. So you can find those articles directly by searching. You can also often find it by the keyword in the actual title. We didn't have the time or capability to actually copy the abstracts. The links go directly to, for example, the Lancet. The links go directly to, for example, the New England Journal of Medicine. or directly to the Royal Academy of Physicians. So you have access to the whole article for you to use, review, and it's important for me to point out to you, you can also look at the references which reference other articles that may not have yet made it into these repositories. Here's another large meta-analysis. You'll have all of these archived in the presentation, so you're welcome to use these links to find the actual articles to do your own work for your own country. Emerging artificial intelligence-empowered mHealth scoping review, and it covers probably about 500 to 600 articles in total. Your global clinical engineering community, a teamwork of IFMBE and GCEA, also provided dozens of webinars on digital health topics. For example, we had webinars on cybersecurity, care processes. We helped WHO put together their first compendium of innovation and innovation technologies for low resource settings. We had congresses. We had a congress in the middle of the pandemic. We had an ICEHTMC in Washington, D.C. at the AAMI headquarters, where we featured hundreds of articles in the midst of the pandemic to share information and papers. And then a number of publications linked here, one of which was published in the U.S. National Academies of Medicine. Here's an example from our colleague Lu Jiamin from China, talking about telehealth, digital health in China. They have an interesting and unusual situation in China that you may know about. This talks about how they've applied their care paradigms to that. Our colleague Axel Wirth talked about cybersecurity and the challenges of ransomware and social hacking into medical devices and medical device systems and medical device systems of systems. We also looked at workforce development. One of the challenges we have around the globe is we have to train physicians, engineers, nurses, patients how to use digital technologies, how to use them properly. It's hard enough to train a nurse or physician on how to use a blood pressure monitor or pulse oximeter, but to train an elderly patient at home with their family how to use it properly is another challenge, and how to interpret the data. So we had a lot of workforce training. This particular one is looking at the UK, and a fantastic model. They called it, the two actually models, pulse oximetry at home, where our colleague Dan Clark helped the UK government select low-cost $20 pulse oximeters to distribute to patients who were having some symptoms to help them stay at home to be sure they didn't become acute. And then they also created what's called a virtual COVID care ward, where patients could be discharged from the hospital rapidly with their own kit, so they could manage their pulse oximetry, temperature, blood pressure, to ensure that they didn't have an acute episode that might return them to the hospital. And here's an example of an article and a training from Colombia. Our colleague, Dr. Manish Kohli, working with hospitals in Colombia, creating what he describes as a digital runway. Many parts of the world can only be served by railroad or airplane. And this is a work in process in our new PULL Alliance, which is working with low resource settings to help provide digital tools. Often they have access to cellular networks and at least some internet access, but they don't have physical access. So we can provide nursing, logistics, consultation via the internet. And wow, as I read these articles, my head exploded. Who ever thought we'd have articles about teledentistry and teledermatology and telewound care and telepathology? There were so many tele-everythings. Every time I read another article, I was amazed. Tele-orthopedic surgery. Things we could never imagine were invented and shared with the world. As you look in your countries, as you look in your regions, you should mine this treasure trove of information to find innovative ways to accelerate your deployment of telehealth and telemedicine. Down the bottom, virtual intensive care and intensive care at home. That's a modality that the US, UK, and others have pioneered. Now, it kind of makes me scared to think about sending patients home with a ventilator, a pulse oximeter, blood pressure monitor, infusion technologies, and tell them, good luck. It's like sending them out on a life raft. On the other hand, if you have no beds in the hospital and you have patients who are acutely ill, it may be better to send them home with these things and keep them on an electronic tether so they can get care in a more comfortable and safe setting. The goals of the project really were to share with all of you, with all of us, all of the global literature. We have archived it. These are curated articles. We didn't write them, but they are available because of an agreement with the publishers and WHO to allow the public use and reuse for life care applications. And I really encourage you to take advantage of this free resource at this link. These are available to you 24 hours a day, courtesy of the Global Clinical Engineering Alliance. And again, thank you all for the work and support you gave us during this over 3.5-year project where we curated these articles. My colleague Rosanna Rivas from Peru was an active daily participant in making these things happen. I couldn't have done it without the team that allowed us to work together on this project. Thanks again. Okay, our next presentation. It's exactly 15 minutes. I did it. Who's our next presentation? I'm sorry? I don't have a printed version. Can I borrow this? Oh, is Tazeen, is that recorded? Okay, so could you start it up, please? Our colleague Tazeen could not get here because of, I think, visa complications, but we should have her recorded presentation for you momentarily. I haven't even looked at it. Was it not recorded? Okay, apparently this was not recorded, so I will try to go through it very quickly with you. Please bring it up. Tazeen works in a hospital directly. She would meet with us in Zoom in the hospital. She was working there almost around the clock, and she had a baby during the middle of all of this and still managed to make this happen. I don't know Saeed Bukhari, but I believe Saeed was also on many of our IFMBE and CED calls. Next slide, please. Next slide. So in Pakistan, they worked on quality assurance for PPE. Of course, all of us found out suddenly we were all trying to buy the same masks, gowns, gloves from the same supply chain, and none of us had enough of them. So every country started manufacturing their own and coming up with ways to manage quality control. And local manufacturing became a key for that. And Pakistan, this is an example of what they did. Next slide. And in fact, that's what happened here in India in this very facility. AMTZ began producing PPE very early on for India at large scale. Next slide. So local manufacturing, all of us realized that we can't all pull from the same global supply chain simultaneously. One of the rules of ISO 9000 is to have optimized suppliers and not have diverse suppliers. However, in a catastrophic or pandemic situation, that doesn't work. We've leaned out, that's called lean manufacturing, we've leaned out the entire global supply chain. So strengthening quality testing infrastructure. I can tell you at MEDIC, when I ran MEDIC's medical device manufacturing program, one of the things we made was alternating pressure mattresses, which are very simple vinyl inflation systems. But it was very hard to do quality manufacturing even with those simple devices. Next slide. So prior to the pandemic, Pakistan imported most of its PPE from China, as everyone else did, low source, low cost, and reasonably high quality. We had insufficient supply and quality, and so Curis analyzed data, and they found that there was not enough resource for Pakistan. Next slide. And of course, large global suppliers, whether it was Amazon or JCPenney or anyone else, purchased the global supply chain for months ahead, and none of us could access the rest of it. So complying with health standards, strict health standards, and good manufacturing practices, which are statistical-based processes, is not easy. It's not easy in a normal situation. I lost most of my hair doing that when I was a manufacturer of pharmaceuticals and medical devices. You have to do quite a bit of design, sampling, and methodology in order to satisfy good manufacturing practices. Next slide. So facilitating local manufacturing, especially with PPE, where we're dealing with specialized textiles, multi-layer, poly-based, porous, semi-porous materials that had to be properly fused together with earpieces or headpieces. All of us know a lot about that, and unfortunately they're littered all over the world. But how to manufacture those in quantity at scale reliably and safely is not easy. So teaching the manufacturers how to meet ISO standards, good manufacturing standards, quality assurance standards, is a very steep learning curve. It's a lot different than toilet paper. It's a lot different than home soap. Our standards and requirements in healthcare are higher. Next slide. Quality testing infrastructure, donor organizations supported. So we had a number of donor organizations, the Gates Foundation, the Clinton Foundation, and many others who helped expedite and accelerate the development of technology. Their local organization helped provide support with equipment standards and specifications. For every kind of material, you need a different kind of device to cut it, slice it, fuse it, connect it, and assure the quality and reliability and packaging is all in an adequate, if it's not sterile, but it's at least properly clean for distribution. And the packaging has to be appropriate. Even the packaging and labeling is under good manufacturing practices requirements. Next slide. So the manufacturers are now capable of producing these products, and fortunately, I think pretty much around the globe we have that capability. Of course, now exactly how much capability and capacity do we need? We're all discovering that as we go. But we have built, I think, an infrastructure in most countries where we have people at the national level who understand what has to be done to manufacture medical products at a reasonable and acceptable quality level. Take the tour around here. Take the tour around AMTZ, and you'll see how they did that for India. Next slide. Next slide. Okay, there's our colleague Tazeen. Please feel free to contact her. She's brilliant. I'm sure she'll share whatever knowledge or information she has with you to help you in your own country. Okay, next slide. I think the next slide set is Tom Judd. And I don't think Tom is here. Oh boy. Imaging being reduced. That's a visual echo. Yes. Did Tom record this? Did Tom record this? Tom Judd? Well, I can narrate now. So pretend for a moment that I'm handsome Tom Judd instead of a lowly Elliot Sloan. And I will narrate Tom's a presentation because it's very closely related to my first presentation. Tom and I met almost every weekday during the pandemic to build and produce the Hacking COVID newsletter and to build the archive. So this is a bit of information about his perspective on the Hacking COVID experience. We're not seeing the slides. Okay. And this will give me an opportunity to give you a little more background about the Hacking COVID process. Tom, in that role at the early part, was the president, the chair of the IFMBE Clinical Engineering Division, and he was also one of the co-founders of Global Clinical Engineering Alliance. And I have to say that really Tom's enthusiasm about hacking COVID and the sharing of the global literature with you, our colleagues, was what allowed this to happen. I was just passionate about feeling that really people had a rare opportunity to see information that was valuable. As an academic person, a writer, researcher, publisher, it's very hard for me to get access to expensive journals like Lancet or other publications. However, this pandemic allowed us to get access and share it with you. Next slide. Yes, I did lead it. Yes, I was the lunatic, literally the lunatic, who read the global literature, scanned the global literature, and selected and curated the articles. The articles that I found were then presented to this panel of referees, including Yadin, Tom, Rosanna, Luis, and Kelleroy. And every day we went through them, and we made sure that the ones that were published were in fact authentic articles. They weren't just self-promotion of a manufacturer. They weren't make-believe articles about theoretical. They were actual applied clinical engineering useful tools. Next slide. The goals in first was to spread information. People needed to know how to make PPE. They needed to know how PPE could be tested. They needed to know how to distinguish between N95, KN95, and all the different varieties of masks and gloves. We also found an enormous need for information about oxygen, ventilators, oxygen concentrators, the use of innovative technologies. If you read some of the articles, there were helmets designed in Italy that were like diving bells that allowed localized oxygen. It's sort of like literally like a diver, an early diving bell with a helmet. And there were continuous high-flow oxygen. And all of these articles were enormously useful to our colleagues. So we curated them, we provided them, and we found hundreds of relevant articles every week. I think Tom has found a few particular areas in here to focus on. Next slide. Ventilators. So Tom looked through the articles and found 40 subtopics in the hacking database directly relevant to CE practitioners, device comparisons, manufacturing and design, EUAs, emergency use authorizations. So there were provisions made, for example, to use an anesthesia ventilator as an intensive care ventilator. There were provisions made to adapt CPAP, continuous positive airway pressure, to use supplemental oxygen in order to provide life support where it was needed. ECMO, extracorporeal membrane oxygenation. There were a lot of interesting applications of this high-flow nasal oxygen. Decontamination, CPAP, home care use, oximetry, oxygen concentrators, strategies. We also got involved with WHO and published WHO's recommendations for oxygen systems. Constant flow of relevant information allowed our CCE colleagues around the world, and here is handsome Tom Judd. Do you want to take over this, Tom? This is yours. This is number 3. Tazeen was not here, so I had to review hers.
Thank you for doing it. I wonder if clinical engineers have to ever adapt to changing situations. Yes, we do. Cool. All right. Oh, so this is talking about the tsunami of articles, right, Elliot? I'm on the right wavelength here? Right. How many of you tried to keep up with all the articles coming out that were clinical engineering related during COVID? And I've seen a couple hands, but probably you were too overwhelmed with your daily work to see, okay, what is this saying to management? What is this saying to physicians? What is this saying to engineers? This tsunami of articles that I know Elliot's probably brought up already. But a couple things happened in late March 2020. And one of them, and I'm really leading up to telling you a hero that this gentleman to my left is. He didn't do it by himself. You're not allowed to speak. So Adriana called Yadin David and I the next to last Friday in March and said, help. Because WHO was being overwhelmed. She's unbelievable. She's an angel, but she couldn't do it by herself. Respond to the tsunami of challenges related to COVID. But the next week, we said, one thing she said is, China wants to give 1,000 ventilators to New York, and we don't know anything about them, they're Chinese. And Yadin said, I can solve that over the weekend, what else have you got? And he did. I mean, he found 100 hospitals in China that said all 3 of these ventilators are great. So the second thing she said is, I need people to help me. And we said, this is a good call because next week we're having one of our CED meetings like Fabiola leads now, monthly meetings, and 55 colleagues showed up and we began to help her. But that same week, this crazy guy said, I'm a professor, I know, I can see all this literature coming in through these various channels. Why don't we form a team that would vet, maybe that's a word you understand, we can qualify the science of these and the management context of these and start to get them out to the community every day, every weekday, Monday to Friday. And we started that, he started that, and 800 weekdays later, we stopped it. Do the calculation, that's about 3 years. Weekdays. So what, that's 250 out of 365 days a year. So that's over 3 years to get to 800. Anyway, I'll stop. But out of that incredible database of articles, what can we clinical engineers do with it now, post-COVID? So this was a little bit of a deep dive to some of those articles that I found in that database, which is equally available to you for free as it is to me now. And I found out things about ventilators, and you can see what about ventilators, but some of those would resonate with your work. What about oxygen? What about CE practitioner and health technology leader responsibilities? It's an incredible resource. Let me keep going. So I think I'm done. Over to you, Mr. Moderator. Because there's other presentations at this Congress about other things people found in the repository, but my message is, it is such an incredible, rich database of how many gazillion articles, right? Thanks.
He said crazy, I said lunatic. Hopefully these articles help you. That's the whole purpose of the work, to make this visible to you, our colleagues, so you can innovate in your own countries. Next, we have a presentation from our colleague Pedro Galvin. Again, I hope this is recorded. So I have to pretend to be Pedro Galvin now, Dr. Pedro Galvin from Paraguay. I'm wearing a lot of personas today, and I'm sorry he is not with us to present his own work, but really, he was one of the earliest participants in terms of innovation at the Ministry of Health level in applying the university and clinical engineering skills and team to accelerate a very small country's ability to triage and manage patient care. Next slide. He has a great team of engineers, people from the Biomedical Engineering Department, the Ministry of Health, the German Paraguay University, and the Basque County University in Spain. So they had a collegial network that helped apply AI tools, and the focus of it was using CT images where they could identify emerging. If you recall, early in the pandemic, we discovered very quickly that merely giving oxygen and ventilation actually killed some patients. Giving oxygen too early was toxic. Giving too much oxygen was toxic. So trying to determine which patients had what damage to their lungs. And in reading the articles, if you have not, you should look at them, because the images of the lung were not characteristic of normal pneumonia. They were characteristic of an unusual physiologic pathology that AI could help determine. And physicians identified this relatively early on, and what they were able to do in Paraguay is create an AI system that could diagnose patients emerging COVID and predict their need for oxygen care. So they have a lot of challenges in Paraguay with universal coverage, as every country does. They have limited resources, as every country does. They have limited physicians. I'm told that in almost every country we only have about half or less the number of physicians that we need per patient or per citizen. The challenge for clinical engineers is to develop a digital health system that fulfills the services in the future. We need systems that help accelerate physicians and nurses and patients' ability to make decisions, the right decisions, informed decisions about medical care. We can't afford to waste resources. So they had a study where the results used telediagnosis. So that's another new term, telediagnosis. I started using the term, I can't even remember, there were so many tele things, we ran out of terminology. A strategy to support digital organizational transformation and future readiness for health services. For these purposes, type and frequency of diagnosis performed was determined. They looked at the utility of telehealth service as a tool to implement digital organizational transformation, future readiness. Look at this number, 620,000 telediagnoses performed in 67 hospitals and almost 400,000 ECG diagnoses, and they came up with 62% normal, 12.5% unspecified, bradycardia, low breathing, teletomography. Woo! I continue to add to my tele understanding. And also accidents and head injuries. Oh, and ultrasound. If you were reading the literature, ultrasound emerged as a fascinating new modality for COVID diagnosis and also cough analysis. It turns out that a person with COVID has an unusual coughing pattern that can be detected and diagnosed remotely. So it was another fascinating emergence. I think if you want information, what Dr. Galvin is suggesting is you contact him directly to share his information. I was absolutely stunned at how rapidly his team, I think by May, the first May of the COVID pandemic, they were already using these tools in the Ministry of Health for patient screening. One of the advantages, an observation that I have, one of the advantages that a small country has is it can act more quickly than a large country like the US. It can be more nimble. It can be more agile. And I really encourage you to think about that as you think about how to deploy and use digital health and telemedicine in your own country. Because you can do things, you can leapfrog past larger countries, Europe, EU, larger countries like the US, UK, and make innovations. Now, you have to do it carefully and ethically. So you need informed consent. You need to make sure that patients don't get harmed. As Hippocrates said, first, do no harm. We have that obligation in working with clinicians and physicians, but we do have a tremendous opportunity as clinical engineers to accelerate our ability to provide patient care at the lowest cost, at the highest quality, at the best safety. Our next presentation is Jean Nagoy from the UK, and it's COVID-19 Floating Intensive Care Unit, Resilient and Agile Response to ICU Capacity. I assume that's recorded because his other one was recorded before. Okay. So I'm off the hook for a few minutes.
Children's Hospital introduction of new technology. That was a way, was on the way prior to the pandemic. I was asking to think about innovative solutions. To keep in mind that pre and post COVID-19 management of health technology, knowing that purchase orders of NHS stateside ventilators and other equipment through our rolling replacement program was already in the works when the pandemic struck, and that the government has already purchased, have stocked all the orders, and have purchased every device that was on the market so that they can be distributed to the hospital across the country. So we were facing a situation where we may not be able to receive the equipment that we ordered, but only what was supplied to us. So what we did a combination of an integrated patient monitoring with an asset tracking system, which means we capitalize on our integrated patient monitoring. In the area where the monitoring was already installed, to add other devices, the device that will be mobile, we tag them with an RFID, we put RFID tag to them. So that when the COVID-19 peak was high, we could take all the equipment in the hospital across other areas of the hospital that were not used, and we bring them into COVID areas. And when the peak was low, we go through infection control, bring them, and put them back into use into some other areas. And that did help us to avoid bringing in a large number of brand new equipment, knowing that we won't have any more resources, specifically financial resources, to accommodate new contracts or new service and maintenance post-pandemic. So what happened is we created a small project using GS1, where we added passive and active RFID to infusion pump, large volume pump, syringe pumps, feeding pumps, thermometers, and other medical devices such as ventilators that will be found in ICU areas and that we can deploy, or we can request when there is a high peak of pandemic, or we deploy elsewhere when there is a low peak of pandemic. So here is the result. First, we converted our overall recovery area as an ICU. So the picture on my left-hand side here are my colleagues. Just at the beginning of the pandemic, when we were preparing for the first patient to come, we didn't have any patient monitors. We also didn't have more ventilators, more than what we had prior to the pandemic for our 11 bed. So, because the OR was shutting down at that period, so we took anesthesia machines, we converted them into ventilators, and we used the monitoring system on luckily for me, I did learn about all the equipment to go into ICU bay at that time, into ICU area. At the beginning of the pandemic, when we were watching on television what was happening in Italy, I had a privilege to call my colleague Ernesto Lazzaga, and I asked him, can you tell me what are the devices that will make up ICU bed, or specifically COVID, because I don't know. So he gave me some rough number, and he said, well, we need ventilators for each bed, we will need pressure monitoring with invasive, non-invasive pressure blood pressure monitoring, we need the temperature, you will need SpO2, etc., etc. You will also need at least a minimum of 5 stretch pumps, or 2 to 4 large volume pumps, you will need feeding pumps, and all the other accessories that he explained to me, and I took note, and that's what we fit into these areas. So then the essence of this project was now, how can we deploy and redeploy medical equipment? So we established a list of medical equipment required, we convert the anesthetic machine, we relocate and tag all the other moving equipment with RFID. And then we developed a custom-made tracking system using Wi-Fi and RFID to track the equipment wherever they are. So we will leave the equipment into ICU. Then, as the peak goes down, the equipment will be moved into other care areas. But when we learn that the peak is up, we had a cart which have the Wi-Fi antennas. We will walk around the hospital and collect the equipment with which are tagged and bring them back into ICU. So what we have learned, what we managed to do, we managed to actually, we were one of the few hospitals that didn't increase a large capacity of the assets. Because after that, we were worried about the cost of maintaining, of servicing them, and also the space. So far, we do not have idle equipment that is sitting in a hospital and that doesn't do anything. In fact, because we kept our original rolling replacement program at the end of the pandemic, we have a majority of our equipment for ICU were actually new equipment, which were replaced normally as if we were replacing our normal rolling replacement through a capital acquisition, which made a very, very big difference. This work would not be made possible without the help of all my colleagues from medical physics in 9 wells at NHS, and also a lot of our colleagues from the Scottish Government whom we collaborate. I will think here of Ted Mullen, who were in charge, and Kate, who were in charge of dispatching these devices, and whom we went through a lengthy discussion, and at some point choosing to take the brand new equipment, brand new ventilators, because they didn't fit in our model. At the beginning, it was kind of why are you refusing equipment that is given to you for free? We say no, because after the pandemic, this will be about, we will know what to do with the equipment, and we may end up scrapping it.
You know, watching this presentation, what isn't stated here is all this needs is brilliant, innovative, committed clinical engineers. These kinds of transformations don't happen on their own. The ability that our colleagues showed around the world to innovate rapidly in response to the pandemic is awesome. Hang on. Wait. Just wait a minute. We have two presentations that are missing. I just want to mention them from Kyrgyzstan, Talant Sultanov, how can digital technologies help rural communities in times of pandemic. Hopefully we will get that presentation and be able to put them in the proceedings. And from the island of Grenada, Dr. Baptiste, Pandemic Solutions for Grenada. Caribbean islands are a unique environment with unique challenges because each one is an autonomous country. So the ability to share resources is really challenged, and to access resources is really challenged. The currencies and the standards are different island to island. And I did a lot of work with the English-speaking Caribbean about 15 years ago, and it was quite a shock to realize that they could not exchange test equipment, spare parts, technicians easily from island to island. So even though they were only a short airplane or boat ride away, they couldn't easily collaborate. We have one more presentation from James Ware on preparing your hospital for a natural or man-made disaster. And since we're running ahead of schedule, we'll have an opportunity to dialogue, answer questions, and talk a bit about what we've learned as a community about applying lessons learned from the pandemic for low and middle income countries. Okay, you can start with James Ware's presentation. Dr. Ware is a good friend.
towers down, we had our orders and emergency generators getting power to the equipment, as well as communication. Communications is a big part, as well as the treatment and movement of patients. The plan, communication among the staff and to the outside world is critical. And again, as you practice the plan, it shouldn't be just a desktop practice. You need to have people actually doing things and communicating to the outside to be sure that things are really going to work whenever a disaster actually occurs. Thank you for listening to me. If you have any questions, you can send them to me on an email. I'll be glad to try to provide you an answer. Again, be sure you give me some information and give me a way to contact you back. Thank you very much.
All right, thank you, James. Dr. Ware, a context, I know this was hard to hear because Dr. Ware is retired. He actually developed and ran the biomedical engineering program for the United States' largest hospital system, our Veterans Administration system. And so he has firsthand experience with disaster planning for the largest health system in the U.S. And I would highly recommend that you look at the presentation on your own and use this to help you improve or develop your own disaster planning programs. If we learn nothing from the pandemic is that we really, despite all of our best plans, have not fully understood and embraced all the possible disaster scenarios that we face. And I'll give you just one. What if someone takes down the web when we have already moved a lot of our health services to the cloud? What will happen? What could happen is disastrous. It makes my heart stop to think about what could happen. And actually, there are hospitals whose systems have been locked by ransomware, and there are patients who have died because the hospital systems were locked. So we really do have to look at disaster planning for the 21st century very, very, very carefully. We have an opportunity to ask questions, to discuss, to dialogue about the many topics that we've talked about: telehealth, telemedicine, AI, disaster planning, the redeployment of resources, which is really a disaster planning in the UK and Canada in what was done is redeploying anesthesia equipment and also redeploying children's beds for adult patient care in the pandemic. So if anyone has a question, here's a microphone. I'll be glad to bring it around. I think that this is live right now, so I can bring it around. I think this one's live also. So would anyone like to ask any questions or bring up a topic for discussion? We have plenty of time for you to discuss or ask questions. Plus, it gets my morning walk, so I get some exercise after sitting on the bus for a couple of hours.
Thank you. Well, I would like to comment something because of what you said about James' work. The context is very important for the different circumstances that we live in. And by this I mean the geographical formation of a very important example. I live in a country that is always attacked either by earthquakes or hurricanes or some other kind of natural disaster, potential disaster phenomenon. Yeah, lately we had a very tragic event in Acapulco, right? We had a very strong, they say that this is the strongest hurricane ever that we had. And it formed in a question of hours. Yes, they were told us that there was an important hurricane to the port, but in a matter of hours, this hurricane became a strong monster, and people were not ready to move. And the problem is not only that, but also that the health systems in that state is difficult to deploy because of the geographical barriers. We have mountains, we have communities that are isolated.
And there's only one major highway into that area.
Yeah, and people tend to move to the next state to attend their health. So these kind of solutions seems to be very effective to deal with these situations, mostly because of people really look for something to be helped. And in case of health, people try to tend to the health facilities, but at this situation, they needed, because they could not move, they needed to stay there until the help came. And help came quite lately, as usual. but mostly, help, in terms of these technologies, help may be reachable and a timely manner. So these kind of topics must be discussed in a level of Minister of Health, in a level of planning, strategic national planning, so we can take advantages of what we are looking at it now. That's what I wanted to comment. Thank you.
Yes, let me expand the thought. You know, Acapulco is an example of a tragic sudden disaster, as is an earthquake or a volcano, where we have no warning. And we don't have a lot of good information or answers to it. Hurricane Katrina destroyed the New Orleans area and the Gulf. I live in Southwest Florida. We had Ian, we had Irma, and it destroys the highways. Tele-everything is one of the potential capabilities that we have that can help. Of course, you need radio networks, you need cellular phone systems, you need internet services, even for that to work. You need power. We didn't have power or electricity in Sarasota, Florida after Irma for 2 or 3 days. And I'm sure in Acapulco, it's weeks before power and all the communications begin to be restored. There's no perfect answer. Fred Hosea has been proposing for years, and Yadin David, that we figure out a way to collaborate as a clinical engineering community to share resources or information. I mean, it is interesting to think about, well, if the local hospital has been devastated, perhaps a hospital in Houston could provide nursing advice or guidance in an emergency. Maybe we should partner with Doctors Without Borders, who have people all around the world and have experience in lending hands to emergency situations. I don't have an answer, but it does seem from what we're reading and experiencing that the scale of disasters is accelerating and the impact of disasters is accelerating. And we are all dependent on technology. We're all dependent on infrastructure. And when the day is done, we're the men and women who are going to deal with the infrastructure. The doctors aren't going to, the nurses aren't going to. The physical plant people will deal with power, they'll deal with oxygen and piped gases, but most of the other technologies we're going to have to deal with. The example that was given yesterday, what's being done in Haiti, with Ray Dalton, is perhaps an example where you have a ability to provide some, at least modicum of electronic medical record, electronic health record, and access to spare parts. But it's a big challenge. Just because somebody needs a replacement X-ray tube doesn't mean that you can just take your hospital's X-ray tube, put it in a box, and send it to them like Amazon does. It's a capital asset. It is maybe matched specifically to your X-ray system, and how are you going to get it back? And what if it's damaged in shipment or lost in shipment? There are a lot of underlying issues here. And does anyone have any thoughts about this? I mean, this is an everyone play exercise, because it could happen in your neighborhood, in your country tomorrow. I just did. Yes.
Hi everyone, this is Millicent. I just want to give a thought on pandemic preparedness, especially going by small man-made disasters. One of the things that I really liked about the very last presentation is the fact that we need to have backup plans. I was looking at the oxygen pipe being disconnected. It may look very simple, and probably might not need a lot of preparedness, but it is something that is worth taking in consideration that if the oxygen pipe is broken today, then you're going to lose connection to ICU, to very critical care areas in the hospital. So for me, I would talk about the very minor or the very small disasters that actually happen within the hospital, that we really need to take care of that by ensuring that we have backups. Looking at water, there's probably blockage somewhere, there's no water flow. Or maybe there's a broken pipe from the municipal supply. And so the hospital runs dry. Do we have like a tank, a reserve tank to have this done?
We all ran dry during the pandemic.
Yeah,
there wasn't a country didn't have.
Yes. So I think we also need to look at the global standards for emergency preparedness. I think JCIA has very nice guidelines on what biomedical and clinical engineers are supposed to do during the pandemic. Thank you so much.
That's a great question. Thanks, and a great observation. And so, Fabiola, I have a suggestion, for the group. It isn't just for you. Maybe we can create some specialized teams, an oxygen response team, another team related to anesthesia services, another team related to imaging services, another one related to laboratory services. So at least we know who the top 5 experts are in these areas. One of the advantages of disasters is they don't generally strike everyone like the pandemic did. They are more typically like a hurricane or an earthquake or a tsunami, or a volcano, which is localized. And maybe if we had an emergency response team in many different areas, pediatrics, diagnostics, telemedicine, cybersecurity, maybe it would be something that we could have subcommittees that created an emergency calling list, so at least you would know who to call, so that we could mobilize at least technical knowledge. Maybe not spare parts, but at least telling someone how to use a stopgap measure to get a system back on the air.
Looking at what Adriana did, I'm just remembering what Tom Judd was saying up there, that she had to call like different people to support in the development of different. So if we had that, technical working group, it would have been very easy for Adriana just to pick and say, hey, who are the people who are very well versed, the experts in the oxygen management, and who are the people who are very good in radiology. So I like that idea. And actually, it resonates with what Tom Judd said earlier, that, look, we were called. And I think from Adriana's head, she was literally looking for people like, I don't have who is in my head. I mean, who can I reach right away to help us, support this? Yeah. So I like your idea.
Yeah, I mean, that would be an interesting thing for us to work on. And maybe in each region to have an identified point person in Mexico. So if a disaster happens in Acapulco, I don't know who to talk to. But if I know who the contact is going to be contacting me, or the team that's going to be the first response team in Mexico, in Paraguay, in Grenada, then at least we can maybe have a little easier way to collaborate with the right people.
I have an input.
Sure.
Mohini from AMTZ. So talking about what Millicent said, there are tools that we have seen on the UNICEF and WHO website with guidelines given for end-to-end services. So for example, let's take oxygen delivery services. There's a UNICEF tool called Oxygen Systems Planning Tool. So all you need to do is, based on the country and the resources that you have, you input in the parameters. So for example, oxygen lines, oxygen concentrators, solar powered oxygen concentrators. Based on the resources and technologies that you have in your country, it will automatically tell you how you can plan for the pandemic and epidemic. So maybe education seminars or some sort of a newsletter where we can disperse these tools all across the globe in our networks, so that they're aware of the basic hospital planning services available online in all languages and easy to download very small bit size. So even in your basic computers or monitors, screens, whatever you have, even your phones, it's very accessible. So maybe if we can have some sort of an education module prepared or some sort of a newsletter system where we update, or one team dedicatedly sits from our side to update these tools throughout the globe, that could also be.
That's a great point, and it brings up another aspect, and this is something Fabiola and I discussed. It's another one of my crazy ideas, which is to have a clinical engineering library where we could go to find the oxygen information, to find the telehealth information. There are many sources around the world, WHO, PAHO, there are many societies that have created resources. But you're like me, you use Google to try to find something, and you find 800 somethings, and you don't know if they're current, you don't know if they're reliable, you don't know if they represent one manufacturer's very proprietary approach, you don't know if there is some kind of embedded worm or virus in the Excel spreadsheet or HTML or link. So having some kind of clinical engineering library where we could go might be helpful, but of course you folks have to help create it, because I'm not crazy enough to do that alone.
Okay, well, I think it's a very important point that Elliot has mentioned it, and we have discussed it. Yeah, the importance of have a repository at least of the point documents, not only articles, but also documents, reports, technical reports, data sheets, anything that could be helpful for us. And I think in that sense, what he did in the repository COVID, the hacking coronavirus, is vital. Yes, because we are surrounded of information, mostly fake information, that may drive us to a fatal decision. So we have to be careful on what we are looking for. So the experience from hacking coronavirus may be very helpful for us to develop strategies, no? to select the correct documents and to put it in an Excel sheet and with links. We are doing this kind of efforts with the Women in Clinical Engineering project. We are collecting the reference of the publications of our female colleges. And what I do is to collect the DOE link or the link where the report is, and as easy as this. But I know that I can trust of the sources because they are my college, but may not be sure as on other kind of reports and other kind of documents. So we have to be careful. And if we can share this information in a WhatsApp group, we don't need any more sophisticated systems, no? If we can share this information and double check the reliability of this, we may conform easily and rapidly base it an elemental set of documents that may be useful for everybody. So this is the invitation for all of us to join to this effort and try to organize us to make this a reality and base it on what he says and what he did in hacking coronavirus.
Thank you. I think we had another comment here.
Yeah, good morning all. I just wanted, I'm not aware if you can clarify it, that there is there is a essential list of medicines published by WHO. Essential list of medicines published by WHO.
Yeah.
So this is the requirement of medicines that has to be stored in a primary healthcare center and secondary healthcare center. Like that, is there any compendium? I'm not aware.
I think WHO has a list of essential medicines and a list of essential devices for hospitals, and that's part of the compendium that they're working on for devices. The challenge is, well, there's several challenges, including maintaining it, and also the availability of medicines country to country to country is not always the same. The other problem is that emergency supplies are handled differently around the world. In the US, in the military and the CDC, let's say an antibiotic has a 5-year shelf life. Well, they may store enough for an emergency in a major city like New York City, but after 5 years, they're not going to throw it out. they're going to have to look to determine whether that product is still effective after 5 years. And so the CDC has to extend the life of a product, and that we also see with diagnostic test kits for COVID, but that requires a strategy. And again, maybe this is something clinical engineers could get involved with. It gets more complicated as we add software into this. It gets more complicated as we add smartphones into this, because these are fungible, changeable technologies. Yes, you had a question or point.
Hi, I'm Somrid Rana. I'm from Nepal. I work at the Health Emergency Program for WHO Country Office in Nepal. So I like to supplement the idea that is being discussed right now. So Nepal is a disaster-prone country. On November 3rd, about 10 days back, there was a big earthquake in Nepal, and for this, response activities is being led. So as a part of Health Emergency Program for WHO, I've seen a lot of activities that's regularly conducted in Nepal. So every hospitals in Nepal have a hospital emergency preparedness and response plan for disasters, and similarly simulation exercises on different disasters is being continuously run in the country. Likewise, other kinds of stuff keep happening on it, and there is a one hospital preparedness for emergencies training, 5 days training, which is being materialized in the country. It talks about equipments and all, but while everything is happening, there is a scope for clinical engineers or biomedical engineers to be part of these disasters and move forward onto it. But right now, since the talks is not going on around, this is a missing piece. So while the talks are being there, I would like to supplement by raising this context and putting a stance on how important it is, or this is an opportunity for clinical engineer to be part of disaster management in the country context. Thank you.
A very good point, and that again, that goes to the reality that they depend on us. They depend on us to make the technology work, to repair it, to make it good enough to save babies' lives, to make it good enough to do surgery. And they can't do it themselves, and they don't expect to do it themselves. So having training, and I think having a network of colleagues that we can call on would make this possible. Does it take 5 years? Probably not. Does it take 1 or 2 years? Yeah, I think that's possibly within the scope of what could be done. You're all relatively young folks. I'm looking out at you bright young clinical engineers. You have the energy, passion, knowledge, time to help create this. And you can help perpetuate this for decades. Let me tell you, 50 years ago, I was talking about health technology assessment. I was talking about health technology management. I was testing oxygen systems 50 years ago. That's your stuff now. That's all things you can reinvent in the 21st century. And I'll be glad to support you and help you. I'll be glad to help guide that, but it really is your opportunity to shine and to take over some of the leadership in emergency and disaster planning. Nobody else is going to fight you for that. No physician is going to fight you for helping get the lab back online. No physician is going to fight you for helping get an infant radiant warmer or an oxygen concentrator back online. No nurse is going to fight you for that. So you take the high ground in that. You're there to help. You're the Red Cross. You're the Red Crescent when it comes to the clinical technologies. We're the answer. But we means you. We means you.
There are varieties of the requirement. In US, Arizona, the requirement is different. In our Indian, the subtropical, this Himalayan region, there is a earthquake-prone area, so there the requirement of medical device. But I am talking about like baby incubator, let's say.
Right.
It can be kept in all PHCs. And why I am telling it, because our procurement agencies who are procuring medicines, they depend upon the national essential list of medicines like that.
Right.
They will have a guideline that we should keep in our primary health care like a baby incubator. It has to be taken. And what is the standard of that baby incubator? If it complies, then we can purchase from a vendor.
Right.
Kind of things. So is there any worldwide national essential list of medical devices?
This
In
is what
fact,
WHO
hemoglobin.
is, this is exactly what WHO is working on. This is what Adriana is working on.
Yeah, thank you so much. And that's a very good question that you're asking. So there is worldwide essential list of medical devices. We call it priority medical devices in WHO. If you go to the WHO website, you'll find that. And so currently what I know is there are about 3, the one for maternal health and child, something like that. The second one is reproductive, and then the other one is cardiography or something. There are about 3 essential list of medical devices that we require. So please get into the WHO that we have. Get into the WHO website and you'll be able to see that. I happen to be in one of the committees of WHO and I know that actually exists. And one thing that the WHO team has done so well is working on the specifications. So in that essential list of medical devices, there are also attached specs, standard specifications that can be used to guide the procurement team and even the, the hospital management to be able to acquire the right devices at a very minimal level. So yes, it exists.
And yes, we need to do more. We've covered the children and maternal area with some capability, but healthcare now is much, much bigger than that. And one of the answers may be more mobile health technologies. Everything isn't a hospital. And tomorrow's healthcare is not all going to be hospital-based. We know it won't be. It can't be. So what kind of mobile technologies at very, very low cost, like pulse oximeters? What kind of low-cost things, like there are $100 heart monitors that work with an app that could be moved into a clinic and provide emergency care for seniors who have chronic heart disease. These are things that we should think about inventing new, not inventing or reinventing the wheel, but inventing a solution for the 21st century. These are low cost, these are easy to deploy, these are products that could use older phones. Also, text messaging. There's a lot of information that can be obtained from text messaging, and there are a lot of systems for maternal and child health based on just simple text messaging, getting information about the baby's temperature, respiration, color. Those are fundamental things for a clinician, a pediatrician, a neonatologist to be able to make a determination or a recommendation. Other thoughts? Everyone's quiet back here. Everyone is just like all of my classes at the university. People move to the back of the room because it's safer back there. The professor isn't going to ask questions all the way in the back of the room. Other questions, other thoughts, other observations. Everyone's afraid to raise their hand because you think you'll be volunteering for something. Let me tell you, the way I grew my career is every time something came up that nobody else could solve, I said, I'll work on it. And I became the person who knew the most about defibrillators, and the person who knew the most about oxygen masks, and the person who knew the most about information systems. That's how you're going to grow your career. You need to break away from the traditional comfort zone and take some leadership. Questions, questions, questions. Do you have a question? Sure. Or a thought or comment. You could tell me that I'm crazy. Well, that's been proven.
So good morning, sir. Myself, Dr. Vasanta from Vignan College. Because we are from pharmacy background, especially pharmacology, I just have a query because you have stressed on man-made and natural disasters. So I just want to know whether black fungus, because black fungus has gained a prominent importance in COVID-19. So how we can categorize, it will be coming under both disasters, and how will you justify to it as compared to storage, medical devices related?
I don't know the answer. I mean, that's an area where the clinical engineer and the biomedical engineer, for dealing with black fungus and the many forms of fungus that became lethal during the pandemic and are globally challenging, the mycins, the medications we have not been that effective with these fungus. But this is where an opportunity, I think, exists with the biomedical engineers and the pharmaceutical companies to try to find interventions. They've used ultraviolet, they've used hyperbaric oxygen. There are a lot of different approaches. We as clinical engineers, that's on the frontiers of what we can do. But then how to share that information. That goes back to something that Fabiola has said, how do we share that information so it's available to each of you in your countries so you can help solve local problems? It's an example of one very specific challenge that exists. And I certainly don't have the answer, but some of the answers are here in India. India is the largest manufacturer of pharmaceuticals on the planet. The US gets most of our pharmaceuticals from India, from Ranbaxy, and from others. And so you have the pharmaceutical brilliance and knowledge that are going to help lead the world. So how do we make sure we connect to that? This has been an excellent discussion. I will stay here up front and be glad to talk with anyone who wants to talk more about this. Give you a chance to have a break. We have to move to other conference rooms. If you go out this center door to the left, there's water in cups. I don't know if there's a coffee break per se. Is there a coffee break now? Okay, so we can take a break now, and then we can go on to the other conference rooms. Thank you all very much. And really, I depend on you to save my life. Get to work. Thank you.
Can we have a group picture of?
I am also going to chair this session, and I am going to start with my own presentation. So, next slide, please. So, before I present my paper, I would like to acknowledge a few contributors for successfully completing the assignment on developing regional training modules and operating guides for respiratory care equipment and devices. First and foremost, I would like to thank Dr. Pushparanjan Vijay Singhe, the Program Area Manager of Infectious Hazard Management of the World Health Emergencies Program of WHO CRO, for his continuous support and guidance in completing this assignment. I am also grateful to Nilesh Buddha, Edwin Salvador from WHO CRO, Laura Alejandra from WHO Headquarters, Susmita Das, KG Venkateswaran, Namrata Agarwal, and Neeraj Jain from PATH for their support and contributions. The recent COVID-19 pandemic proved that the healthcare systems in many countries, including the most advanced national healthcare services, were not designed to deal with a protracted crisis of such magnitude and unpredictable scale. The increasing caseloads led to an acute shortage of medical supplies, thereby overwhelming the hospital infrastructure. The second wave of the pandemic, starting in early 2021, struck harder than the first, and there was an inordinate spurt in demand for medical oxygen. The crisis led many hospitals to sound an alarm and place an emergency request to narrow the growing gap between the demand and supply of medical resources, including oxygen, and the rapid spread of SARS-CoV-2 resulted in an unprecedented need for available resources such as healthcare staff, hospital beds, including sub-intensive and intensive care unit beds, ventilators and other biomedical equipment, devices, consumables, and a constant supply of medical oxygen. The governments initiated several measures to rapidly provide these resources and augment the medical supplies to cover the care needs of the multitude of COVID-19 patients beyond the ordinary needs of other patients. Besides, despite the overwhelmed health systems and the relentless loss of human lives in countries that were most affected by the pandemic, global communities, including countries, multilateral and bilateral agencies, philanthropic groups, firms, and individuals, among others, stepped forward and donated various oxygen and medical equipment devices and consumables to these countries. All the countries were increasing their medical resources and capacities. Hospitals and treatment facilities needed qualified biomedical engineers to use these technologies effectively. Very few personnel in the health systems, especially at sub-national and secondary level facilities, were trained to operate these equipment and devices and had the knowledge to understand the complexity of the integration and maintenance of respiratory care devices, especially these newly installed oxygen systems. And even fewer had the relevant skills to operate and manage these newly deployed oxygen systems. And furthermore, the trainings provided by oxygen equipment manufacturers and vendors at the time of installation varied immensely in quality, content, and approach from the training to another. Nevertheless, biomedical engineers from these countries came forward and actively responded to this crisis by adopting their knowledge and skills for the treatment of COVID-19 patients. So, recognizing the huge number of newly installed medical equipment and devices in the member states of World Health Organization's Southeast Asia region, the Infectious Hazard Management Unit of the World Health Emergency Department, CRO, conducted a series of meetings in 2022. The deliberations were undertaken with various stakeholders from the CR member states to understand the biomedical needs for upscaling oxygen and other respiratory care capacities and mechanisms to respond to current and future influenza and other virus-borne epidemics or pandemics. It came out clear that in most member states, the biomedical engineers had limited knowledge and relevant skills to operate and manage the newly installed equipment and devices. Hence, to strengthen the capacities of biomedical engineers and plug these knowledge gaps, WHO CRO along with PATH developed two high-quality and reliable knowledge products, that is the regional training module and the regional manual with operating guides. Both documents are expected to be included in the National Influenza Pandemic Preparedness Plans as annexes for preparedness and response during epidemics and pandemics. Next slide, please. So the goal of this project is to strengthen biomedical capacity for oxygen and respiratory care devices, and the end users are the biomedical engineers, technicians, and health facility managers in the area of biomedical engineering. Next slide, please. Previous one. Can we check the next one? Next one. Can we go the previous one? Previous one. The previous one. Again the previous one. No, I mean previous one. You just go to slide. Next slide. The next slide. And then the next slide. Next slide. Okay. Thank you. Yes. So these documents have been meticulously developed through extensive literature review and by incorporating inputs from several biomedical experts in the areas of respiratory care, oxygen system management, operations and maintenance and related topics. And these are the key steps followed for the development process. For long listing of equipment and developing document framework, a consultative process with PATH's biomedical engineers, technical experts, and other relevant stakeholders was undertaken to understand the requirements of regional manuals and operating guidelines. This was followed by the identification and preparation of the list of equipment and devices for respiratory care and oxygen systems that were to be included in these guidelines. This long list was then shared with the WHO's country focal point. After review and incorporating the feedback, the list of equipment and devices and the structure for capturing the information for each of the operating guidelines and regional manuals were finalized. The topics finalized for the knowledge products are oxygen production sources, oxygen storage systems, oxygen distribution systems, oxygen delivery to patients, patient monitoring systems, patient diagnostic systems, fire safety measures, and biomedical waste management, etc. Then for preliminary literature review, the document development process started with a desk review of the literature available on respiratory ecology, equipment and other equipment related to respiratory diseases from WHO's member states. The literature review involved the evaluation of related documents, including but not limited to technical specifications, training materials, technical documents, reports, checklists, and instructional videos, among others. These documents were collected from online sources from key organizations working in respiratory care management and oxygen systems such as WHO, EPIC, UNICEF, PATH, and the USAID, and also from personal interaction with WHO's point of contact for this project. Other scientific journal articles and original equipment manufacturer guidelines are also used for developing these documents. Then, after review by technical experts and ensuring accuracy of information, conformity with regulatory standards and quality, the documents has been drafted. Then, after careful review and incorporation of all feedback and quality checks, the documents were finalized for dissemination. Next slide. Previous one. Next. 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 Yes. As I have just said, these are the areas covered in these two documents. Next slide, please. Next slide. To supplement the medical oxygen infrastructure developed by the member states in WHO Southeast Asia region, the two knowledge products, one is regional manual on operating guidelines and regional training modules for biomedical engineers are developed. Next slide, please. Regional manual on operating guidelines is for maintaining respiratory care ecology, maintenance of equipment and equipment handling, and other key biomedical aspects of oxygen and respiratory care. The purpose of this manual is to provide foundational information on key biomedical aspects of maintaining respiratory care equipment and respiratory care ecology. This guidance document will give the users an idea of the level of expertise required to install the devices, the types of maintenance required, and the frequency of interventions needed. These guides intend to assist biomedical engineers in performing routine tasks to improve efficiency and compliance with quality standards as well as standardized processes. Each operating guideline provides technical product specifications for respiratory care equipment and devices that may prove useful in the selection, procurement, use, and maintenance of these products, and this document is meant to serve as a complementary knowledge product series to other respiratory care and oxygen management documents. Next slide, please. Regional training module for biomedical engineers is about establishing, maintenance, upgrading, expansion of oxygen and respiratory care systems, and setting up of and ensuring functionality of the biomedical equipment needed for influenza pandemic response in the long run and managing surges of SARI patients due to COVID-19 in the short run. And these modules provides a course plan spanning over 4 days with multiple sessions per day, includes information on medical oxygen systems from their source to their storage to their delivery to patients. And considering the evolving nature of respiratory infections, these modules has also covered diagnostic devices such as ultrasound machines, electrocardiograms, and X-ray machines. Employ participatory learning techniques led by both the trainers and trainees, and the course design provides opportunities for individual participation in exercises and engagement with the facilitator. This module can also be customized as per the availability of respiratory care equipment and devices in the country and translated into the local language. Next slide, please. Some of the unique value propositions of the knowledge products are: it is developed specifically for the biomedical engineers and technicians. It is a standardized, evidence-based, and high-quality training and learning materials which can be custom-built as per the availability of country's respiratory care equipment and devices, and translating the documents to local languages will add value. and it covers medical oxygen systems from its source to storage to its delivery to patients, including diagnostic devices such as ultrasound machine, ECG, and X-ray machines. Each operating guideline provides technical product specifications for respiratory care equipment and devices that may prove useful in the selection, procurement, use, and maintenance of these products. In conclusion, the COVID-19 has highlighted that frontline healthcare workers require rapid and effective learning solutions to upgrade their skills and knowledge for managing a health crisis. This health emergency has emphasized the significance of strengthening the capabilities of both clinicians and biomedical engineers and technicians, not only during the pandemic, but also for any future potential respiratory disease with crisis. The regional training modules and operating guides will serve as regional goods of the World Health Organization for use by health facility managers, biomedical engineers, and technicians in the area of biomedical engineering, especially for oxygen and respiratory care devices, to strengthen oxygen ecology in the health facilities and in the region. These standardized, evidence-based, and high-quality documents will also be available for use as readily available reference materials in the public domain to improve the technical skills for management, upgrade, and extension of existing medical gas pipeline systems and maintenance of oxygen and respiratory care devices for all member states throughout WHO's Southeast Asia region and beyond. Thank you. Next slide. So sorry, actually my English is not so good, so I was reading this. So, but if you want to, if you have any questions or if you need any clarifications regarding anything, please raise your questions. Or otherwise, I would like to call for the next presentation. It is from the headquarters, Geneva WHO. So I think, and the presenters are Jia Shin Kiki He, Florestan, Baulem Laura, Alexandra Belez Gaitan, and Janet Diaz. But I think they are not here, so we are just, okay. Yes, yes, sure. So we have recording here of this presentation, so please have 15 minutes with them. Thank you.
Hello everyone, my name is Kiki He from the WHO. With my colleague Florestan Boella, today we will present to you on the topic lessons learned in the implementation of oxygen generation plants in low and middle income countries as an emergency response during the pandemic. We're looking forward to sharing our insights and findings on this topic based on our experience working in the oxygen scale team. And we hope it offers some takeaways for all of you. Before I start, I would like to introduce you to the technical team. We are part of the WHO Headquarters Health Emergency Program, the Healthcare Readiness, Clinical Management and Operations Unit. Within this unit, the Oxygen Scale Initiative is supporting member states to increase access to oxygen systems. Within the oxygen team, Florestan and myself are both the biomedical engineering consultants. There is Alejandra Belez, who is the oxygen coordinator, and Dr. Janet Diaz, the unit head. The roles of our team range from providing remote and on-site support to regional and country offices in the implementation of oxygen generation systems. And we also provide training and support the development of tools and guidance documents related to the operation of oxygen systems. And now I'll provide some background of the Oxygen Scale Initiative. As we all know, medical oxygen is very critical and considered as an essential medicine used to care for patients at all levels of the healthcare systems. Despite its clinical importance, it remains hard to access in low resources healthcare settings. Particularly during the COVID pandemic, it has highlighted inequities in available medical oxygen and the inherent challenges in the process of generation, distributions, and delivery of oxygen to patients. WHO, as well as other international organizations, has supported the procurement and implementation of oxygen sources at scale to enable autonomy in healthcare settings. Specifically, WHO has supported the implementation of 41 oxygen generation plants in 18 countries today. delivery, installation, and operation of these plants. So the goals of the project and in these presentations are to firstly share a global perspective of the lessons learned to different stakeholders working in implementation of oxygen generation plants in LMICs based on our experience within the team. And an example is the implementation of pressure swing absorption plants, which is also known as PSA, as shown in the picture below. And this will be the focus of today's talk. And secondly, we'll present some examples to highlight the different challenges according to the context and their relevant solutions. So based on the past 3 years of experience, we have identified 5 main challenges for the implementation of oxygen generation plants. The table below shows the challenges on the left-hand column and the respective key considerations to address them on the right-hand column. The first challenge is poor planning of capital, operational, and infrastructure expenses. As the oxygen plants require large upfront capital investment and ongoing operational cost, not only related to the equipment itself, but the need of electrical source, infrastructure, human resources, and maintenance service. Inadequate planning can lead to unsustainability of the plant, and the proposed action is to develop a comprehensive funding plan to consider all this cost prior to procurement. Second is inaccurate or absence of oxygen need gap estimation prior to procurement of oxygen plants. Often there is discrepancy in the actual needs with the proposed technical solutions, which could result in either undersizing or oversizing the plants procured. And this is due to inaccurate or absence of oxygen needs assessment. And a possible solution is to implement user-friendly tools and provide training on oxygen needs assessment and estimation at both facility and country levels. Third is supply chain logistics complexities in transportation of shipment for countries in conflict, which could affect the proper implementation. Reaching certain contexts due to security or environmental constraints, together with the lack of local or regional suppliers, have affected the shipment timeframe. Moreover, these plants are an assembly of different components or containers, which present higher risk for damage or parts lost. And the solution is to enable and encourage more qualified suppliers to reach LMICs and maintain the quality of goods and services. Fourth is lack of planning, coordination, and project management with the multidisciplinary stakeholders throughout the project implementations, which might engender technical errors and cause project delays. A possible solution to this is to develop proper operational guidance and support site preparation planning ahead of procurement. In fact, WHO has been working on this and published a number of tools, annexes, and guidance documents on medical oxygen. Lastly, inadequate technical professionals at country level to contribute throughout the projects, from planning to operationalization and upkeep maintenance. This challenge encompasses the scarcity of technical professionals at country level, low wage, absence of health systems planning, and the unavailability of workshops and basic tools for the operation, maintenance, and troubleshooting of equipment, etc. It's important to promote recognition and inclusion of biomedical technicians and engineers into the health system planning. And this is also the reason why we're here today at the conference. Now I'll pass on to my colleague Florestan to go through some real-life examples for each of these challenges.
Thanks a lot, Kiki, and good afternoon, everyone. So my name is Florestan, and as mentioned by my colleague Kiki, I am a biomedical engineering consultant for the headquarters of the WHO. So I'm going to continue the presentation. I am going to present 5 case studies. For the first example, we are going to focus on installation and operational expenses. This is quite common to see that a country with a limited main grid did not purchase any power generator or prior ordering the procurement of an oxygen generation plant. To easily fix this issue, a power generator must be purchased to ensure continuous and reliable electrical activity. And the housing for the power generator must be built. This is very important prior to the purchase of the power generator to request the manufacturer of the oxygen generation plant, the nominal current, the startup current, and the power for each component of the PSA oxygen plant, to size the most accurately possible the power generator and and avoid to undersize or oversize it, as it will result in overconsumption. So higher costs will be spent for the diesel, and some issues might appear more regularly. Moreover, the primary electrical source must be determined as it will impact the selection of the power generator, prime mode if this will be like the primary electrical source, or standby mode if this will be like the secondary electrical source, as specs for prime and standby mode are different. To consider as well the procurement of earth wire and earth rod to connect them to the power generator for protection of the user against electrical shocks and to protect the equipment itself. For the second example, we will focus on oxygen need gap estimation. The first step in the procurement of any medical oxygen system is to perform an oxygen need gap assessment of the healthcare facility. If this oxygen need gap assessment is not done properly, it might result in undersizing the medical oxygen systems procured. To solve the issue in this example, if the medical oxygen systems procured are undersized for the healthcare facility, a solution could be to procure additional high-pressure gas cylinders that could be filled by an external supplier to reach the oxygen demand of the healthcare facility. To estimate the most accurately possible the oxygen need gap, this is very important to double-check the data with some question for the assessment, such as: is the healthcare facility using medical oxygen production equipment? How many cylinders are used per day for the whole facility? What is their size? What is the response time for the external supplier? If liquid oxygen is used, how often are the tanks filled? What is the filling volume? Is the hospital supporting other facilities at the oxygen level? Is it a central, regional, or district hospital? And lastly, are there any plans of adding new services in the future within the healthcare facility? And will those services require oxygen? The third example will focus on supply chain and logistics. Unfortunately, it is quite common that there is an extended shipment time frame for components to arrive in the country due to security and environmental constraints. An alternative to anticipate and avoid any delay could be by having regular meetings with the supplier, procurement team, and the country office to explore the best alternative options. Country office can sometimes prepare in advance the borrow clear blueprints of the goods. In this new case study, the fourth one, I will highlight the importance of the interdisciplinary management team. The civil engineer was not consulted for the infrastructure of oxygen generation system housing, which resulted in improper ventilation. The alternative in this situation was to increase the openings in the housing of the oxygen generation plant to allow cross ventilation at the time of the installation. There are very important items that should be considered while building the oxygen generation plant housing, such as an extractor, ambient oxygen motor, alarm gas detector, smoke detector, and sprinkler. Extinguisher, trolleys, and oxygen cylinders must be considered as well, even if they are not part of the housing itself, but they are part of the safety management of the medical oxygen. Those are discussions that are very important to have with the supplier from the beginning of the project. And for the last case study, we will focus on the human resources. There was no technician or engineer available in the next facility to operate the oxygen plant. What has been done? The hospital pharmacists were trained to operate and maintain the oxygen plant. Recommendation was made to the local Ministry of Health for the recruitment of biomedical technicians. Human resources is a key factor. Without operators, no oxygen can be produced and delivered safely to the patient. The recommendation we are providing, going from the annexes, the release with the publication of the Foundation of Medical Oxygen System in February 2023 is to have at least 2 operators per shift of 8 hours. Thanks you all for your attention, and don't hesitate to go to our website, Oxygen System, and to reach us by email at oxygen@who.int. The website gives you the opportunity to see our last publication, The Foundations of Medical Oxygen Systems, that has been released in February 2023, and the technical specification for PSA, pressure submersion oxygen plants, released in June 2020, among other contents. A new publication will be released soon, the technical specification of medical oxygen system. Thank you, and please don't hesitate to ask us if you have any questions.
So for next presentation, may I call Millicent Allu from Kenya?
Thank you so much. Can you please put it on the presentation mode? Thank you. Yeah, so my name is Millicent Allo. I'm a biomedical engineer by profession. I work with NEST 360 as a regional director for biomedical engineering, overseeing the African region. And then I also consult for, I also sit in the WHO STAG-MEDEV as one of the advisors. And I also lead the Association of Medical Engineering of Kenya as the Honorable Secretary General. So I have the pleasure to be here to present what NEST is doing in regards to, I think this is not a presentation. Can I have the oxygen? Sorry?
Good noon. Millicent will resume shortly. Maombi Edison will be presenting next meanwhile. Sorry for the inconvenience. Thank you.
Good afternoon, everyone. The presentation, please. Yeah, just some seconds. They're putting the presentation on the screen. It's okay. Maybe I can present myself. I'm Maombi Edison. I'm a physician and biomedical engineer. I'm currently working with WHO as a health technology advisor in Chad. And before that, I have been working with my health ministry as a biomedical engineer expert, helping in different equipment projects in DRC. But currently, I'm working with WHO in Chad. And my today presentation will be about two studies. One is a study we made in DRC on the functioning of oxygen concentrators during COVID-19. And the second is a case study done in Chad, sharing the experience of Chad, how the country is doing in improving the oxygen availability in different hospitals. I think I still need to wait for some time, so. You got it? Okay. Yeah, they got it. Yeah. Okay. Nice. Yeah. Okay. Yeah. It's okay now. Okay, next slide. Okay, I will present you the team. In DRC, we worked with some colleagues from ULB Corporation and also a colleague from University of Liège and the Health Provincial Division in North Kivu Province. And in Chad, we worked with the WR and myself. Next slide, please. Okay, maybe I can give a short introduction to both studies. We all know that the lack of medical oxygen has contributed to a large number of avoidable fatalities globally, which have escalated as a result of the COVID-19 pandemic. And in North Kivu province of DRC, we faced a high prevalence of hypoxemia disease requiring the use of oxygen concentrators during COVID-19. And coming in Chad, at the start of the pandemic, the country had only 2 PSA plants installed in the capital N'Djamena with low capacity to meet high demand. And oxygen concentrators were also not sufficient, and most of them were out of use due to the lack of proper preventive maintenance. So this presentation describes the level of functionality of oxygen concentrators in 31 hospitals in North Kivu province in Democratic Republic of Congo. And also this presentation would address how oxygen needs are being met in Chad in post-COVID. Next slide, please. So the goal of this presentation is just to share the result of a study made on the level of functionality of oxygen concentrators in North Kivu province during COVID, and then to share the experience of Chad in its effort to improve the availability of oxygen for the management of respiratory disease, as well as the benefits and challenges to consider when planning for increased access to oxygen in similar settings. And the beneficiaries are ministries of health in our sub-Saharan region, Afro region, and also clinical engineers in the same area. Next. So coming to the result in DRC, we did a descriptive cross-sectional study with a survey on managerial and maintenance personnel and the removal of parameters on the operation of oxygen concentrators from 31 hospitals handling COVID-19 cases in North Kivu. And the collected data was encoded and analyzed using SPSS software. And the oxygen concentrators were of 28 different brands in 65.8% of cases, with a 5-liter capacity, and they were used in 70% of cases in 4 departments, which are intensive care, operating rooms, emergency rooms, and internal medicine. And they were donated in 66.2% of cases without accessories, and in 33.6% of cases without training of maintenance technicians, and without training of maintenance technicians in 3 of 5 cases, or users in 1 of 2 cases. Next slide. In 45% of cases, maintenance was not provided, and in 67.6% of cases, oxygen concentrators were not functional, with impaired volume flow in 54.9% of cases, and oxygen levels in impaired oxygen levels in 34.6% of cases. The oxygen deficit was variable depending on the type of hospital facility, but not the volume flow. And from this study, we concluded that low functionality of oxygen concentrators increases patient risk and shows the interest to implement the provincial strategy for the management of management and maintenance of biomedical equipment and its integration into regional health development plan. Next slide. Now coming to Chad case study. As I told, Chad health system has demonstrated resilience in terms of the availability of medical oxygen with the help of its partners, particularly the WHO, which coordinated the response. And several measures have been implemented, including the installation of new PSA plant and maintenance and the repair of broken down oxygen concentrators, but also training of technicians. A total of 103 service technicians from 23 provinces around the country got a practical training on repairing and maintenance and maintaining of oxygen concentrators. And we saved 64 oxygen concentrators were repaired during those training sessions. And from the 2 PSA plant, which was formerly installed in the country, now in 2024, the country will be having 13 PSA plant. Last year, in 2022, in December, we submitted 2 projects to the government, and right now we are having 4 PSA plant projects going on in different provinces of the country. Next slide. And the lesson learned, please, previous one. From this study, the lesson learned was that properly maintenance of oxygen concentrators can provide a highly effective, low-cost, easy-to-use solution for health facilities in developing countries. You know, in our countries, we don't have that much PSA plant, and also managing those infrastructures is not easy. So we developed this strategy of repairing concentrators, oxygen concentrators, which are available in the different hospitals, so that we can increase the availability of oxygen. And this is actually a simple solution which can be capitalized in many developing countries. Next slide, please. So here I can show you some pictures. This is, oh, I think it is not working. No, it's not working. So you can see this is the kind of project WHO have been delivering to the country. This is the PSA plant we handed over to the government in December 2022. And it was actually a good idea because due to all this effort, the country was among the highest COVID-19 mortality rate before starting all those measures. But now, after repairing, working on oxygen concentrators, building new facilities for PSA plant, the mortality rate decreased from 4 to 2. So that was very important for the country. And next, please. And here you can see some images. That is how we founded some oxygen concentrators in some district hospitals. And you can see how technicians were very excited to learn how to maintain and to repair their equipment. And after that, you can see how, at the finish, what was the output. And one more thing is that before, there was no oxygen analyzer in the country. So it was the first time to check for the oxygen purity. There was just giving oxygen blindly. But now, in every hospital, not only technicians can repair they can maintain and repair their oxygen concentrators, but they can also check for the purity of oxygen, because this is very important to assure that the patients are getting the good oxygen. So, and one more thing we have done, all technicians now, we have a WhatsApp platform in which they can share what they are doing. If anyone is doing something and he's having any doubt, he can send just a short message in the group, and they are doing a wonderful job with this in the country. Next slide, please. So I thank you so much for your attention. If you have any question or comment or contribution, you're welcome. Any question or contribution or any comment? Okay, they said that it will be at the end of the session. Then, thank you so much.
So may I call again Millicent?
Good afternoon, everyone. Sorry once again for that. The presentation initially was going for the other track, so our track is this one. So I'll pick it up from what the rest of the presenters have been doing. And so I'm going to take us through what Nest 360 has been able to do in order to sustain oxygen access beyond COVID-19. So of course, that's my team. We worked with Kara. Kara is my colleague at Nest 360. So just if you're wondering what Nest 360 is all about, so Nest 360 is an alliance of 17 organizations, 13 of which are in Africa, and they have come together to prevent or to reduce preventable neonatal deaths in Africa. And so currently Nest 360 is in 4 countries. We are in Malawi, Tanzania, Kenya, and Nigeria. And we are currently operating in 67 hospitals. We are planning to expand in the coming year to Ethiopia and Ghana. Now, we're actually just going to talk about basically why Nest 360 has actually decided to continue sustaining the oxygen supply in neonatal unit in Africa. Globally, according to WHO, 2.5 million children die in the first month of their lives. That is within day 0 to 28 days. And more than half of these deaths are preventable. And looking at that globally, we have seen that the major contributors to these particular deaths are preterm birth, intrapartum complications, and infections, some of which lead to something we call hypoxemia or hypoxia, which is the low level of oxygen in the blood. It's a very threatening condition that actually leads to death in most of the neonates. Now, going by the global move and the global commitments, by 2030, SDG 3.2 is talking about ending preventable newborn deaths with all countries, aiming to reduce neonatal deaths in different countries. If you look at the ENAP coverage target 4, by 2025, they're also talking about every small and newborn sick prevention death. And so all we need to do is to reduce the burden, which is very high in Africa. And that's why, if you look at if you're going to look at what Nest 360 has been able to do in regards to oxygen, that has been able to reduce drastically the neonatal deaths in those particular countries that we have mentioned. Now, okay, sorry. Yeah, so Nest 360 has been able to deliver quite a number of technologies. We have delivered 3,381 devices. We identify particular facilities that are really struggling with newborn sustenance, and then we supply them with different facilities. So we have supported these particular countries and facilities through procurement, training, and maintaining of these devices. All these things, you're actually going to look at them. But now, we have not just applied these particular 3,381 devices, but we are very particular in the devices that we are actually supplying. And that's why you're able to see there, we have 23 technologies. We went through a very vigorous something called the TPP, the Target Product Profile, that was able to inform what exactly we need to supply in these particular facilities. And from this, we'll be able to see that, next slide, please. Yeah, we'll be able to see that 60% of those devices that were supplied by Nest 360 are oxygen devices, and some of which have been mentioned here in a very comprehensive way. Oxygen concentrators, the splitters, the CPAP, the pulse oximeters, and suction units. All these ones are actually supporting in the delivery of oxygen across the newborn unit. Next slide. Now, one of the things that Nest 360 has ensured to do is to ensure that every country where we operate in, we have local distributors to be able to maintain these devices, to supply the spare parts. I think my immediate presenter said that one of the things that is causing the oxygen concentrators to be down is lack of spare parts. That is derailed. There's a long procurement process. So for us to reduce this particular problem that was shown in the previous presentation, we have ensured that we have different local distributors across all the countries, and they have everything that is required, the backup devices, the consumables, the accessories, the spare parts, and all that. Next slide. So looking at this, another thing that we've also ensured is supply of accessories, consumables, and spare parts. I normally call it ACS, and we do this free of charge. One of the problems that we experience in Africa is that after people have actually supplied the devices, there's no follow-up in the ACS. Nobody remembers that these devices requires simple things like consumables, the spare parts, and accessories. So you'll find a device getting into the junkyard just because probably there's no pulse oximeter sensor, and you find it there. Oxygen concentrator is there because there's no filter. So Nest 360 has ensured that this constant free supply of these accessories, consumables, and spare parts to be able to maintain all these oxygen devices. Next slide, please. And one of the things that we also do is device functionality. We ensure that we maintain 90% of uptime of all the devices that we supply, and we monitor them across the ward unit. So you can see those are some of the devices that we supply, and we're able to see that from the green line, the last line shows the pulse oximeter, and we're able to note that in all the countries where we are, through our monitoring system, the pulse oximeter seems to be dragging behind in terms of functionality. Most of the time it was down, 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 and we were able to take the various intervention measures to ensure that the pulse oximeter level of functionality goes higher to the other levels. And one of the things that we did is to ensure that we train the clinicians so that they are aware of what exactly is going on in the usage of pulse oximeters, the proper placement of the pulse, the proper storage, handling of the unit. Those are some of the things that were leading to the failure of pulse oximeter. And that's why you are seeing in the graph, it's quite down. Next slide. Another thing is that we've developed quite a number of standards for pre-service and in-service. So pre-service, I mean the people who are still training in biomedical engineering. So we have developed these particular standards to be able to support in learning and in training, the people who are training and even the people who are maintaining the devices. If you go to the Nest 360 website, and I would love you go there at your own free time, please check on this. We have all the devices that we supply. We have the training guide. We call them the job aids for all the clinicians, for all the biomeds, and for everyone else. And this applies to all the oxygen devices that we've actually supplied. Next. We have comprehensive training for BMEs that has also ensured that the BMEs, the biomedical engineers at the facility level, are capable of doing the PPM on their own without relying on the local vendors or even the NEST 360 as a whole. So we've empowered them. Like you can see that lady in Tanzania, we have another lady there in Nigeria. And from the same also, you can see that circled red is a biomed number on the nurses notice board, showing that even the clinicians have actually realized the importance of having biomeds in the facilities. They can easily reach to them, that they can be able to come and do the corrective maintenance or perform the preventive maintenance. Next slide. One thing that I know NEST 360 has done well is to supply the toolboxes and the toolkits for the biomedical engineers to be able to maintain the devices for oxygen. And so most of the time we realize that the biomeds at the facility level do not have these particular tools to be able to support or to maintain the equipment. And so we give them the equipment, we give them the right tools to be able to maintain these oxygen devices. Next. And another thing that one of the things that was mentioned yesterday and even today morning is about AI and just ensuring that you are able to monitor the functionality of devices. This is something that is very hard for the biomeds at the facility level. How do you know that your device is functioning at any given time? And so for us, we've been able to have this device monitoring system called Hadley monitoring. At a glance, I'm able to see whether our device is on or off. And if it is off, you'll be able to see those the red and the yellow. If it is red, then it means the device has not been in use for some time. And so we can clearly call the facility and ask what exactly is going on with this device that has been appearing red throughout our system. And so with that, we are able to monitor the functionality of these oxygen devices that we've supplied in the facilities. If there's a breakdown that requires a spare part, then you are able to supply right in time, just through the use of the Hadley monitoring software. Next slide. And in conclusion, I would say that oxygen provision is important to the care of newborn because many conditions that affect babies in the first days of life can result in low level of oxygen in the body, a condition that we usually refer to as hypoxemia. Next, I think it's actually done. In summary, oxygen therapy in small and sick newborn is key and should be at the center of everything. So for us as NEST 360, we've been able to monitor the BMET data in terms of comprehensive planned preventive maintenance and corrective maintenance. We've been able to conduct comprehensive biomedical engineering training. We have been able to supply the tools 100% in all the facilities where we are, and we've also been able to develop different technical guides for usage. I think that's pretty it. Thank you so much. For any, please you can contact me on my email address. Thank you.
Thank you. He has a question. We can take it later or you can address it now.
Okay.
Question. He has a question for you.
Okay, okay.
Mike?
I don't have a mic.
I get it for you. Come. We can take questions now, but we also have space at the end of the talk. But here you go.
As me, Dr. Engineer Anwar from Bangladesh, I did my PhD in biomedical engineering. Thanks to audience. My question is like so, that we know oxygen is an indispensable medicine today and also used for therapy in order to ensure the level of the blood oxygen, blood saturation. So some cases you go the preventive maintenance. Have you any plan to PPM? Technician knows, engineer knows the PPM duration, have any start after 7 days or 5 days like that? Number one. Number two, as usually, some masks deliver the oxygen, probably infected, some masks, and line also infected from cylinder. And some water is needed to control the humidity. That means oxygen with the percentage of the water, in order to minimize the risks of the oxygen inhalation. So how many the quality of the oxygen from oxygen generator? Is more than 95% or 96%? This is my question from the device outcome. Thanks.
Thank you so much, Dr. Anwar. So starting with your first question on the PPM, yes, we have comprehensive planned preventive maintenance that we shared, and we trained the biomedical engineers at the facility level to be able to plan for their own planned preventive maintenance, because the newborn devices that we supplied are not the only devices in the facility. So there are quite a number of devices across the hospital, and even oxygen devices are not the only devices in the facility. And so what we train the facility biomeds to do is to ensure that at any given time they have a comprehensive planned preventive maintenance that cuts across the entire year, and they follow that. And if you look at our data system for NEST, one of the things that we capture, one of the things that we look at is the PPM as an indicator that it is actually being done, and we have a cut line of 99% for planned preventive maintenance unless otherwise. And the otherwise has to be written down that probably there was influx of patients who are not able to do the PPM because they were all in use. But most of the time we realize that the PPMs are done according to what we advised. Now, going back to the purity, we also, among the tools that I shared there, we've also given the oxygen analyzers, that the biomeds are able to check the oxygen purity using the oxygen analyzers. And in the event they realize that the oxygen purity has gone below the required 95 and below, or 93, somewhere there, then they're able to check. Most of the time it's clogged filter, you know, they're just small things that the technicians know of what causes the purity to go down. So all the 67 facilities are all of them having the oxygen purity analyzers to ensure the purity of oxygen that is supplied to the facilities and to the patients are pure and right standard as per WHO guideline. I hope I've answered your question, Dr. Anwar. Thank you. The percentage is 95%. 95, yeah, we don't get 96, 95.
From different countries, my assumption and real data is make us alarming that when a pilot fly, he is need license, authorized, and a car driver need regulatory license. And in many countries we are viewing self-declared biomedical technician, those are qualified from electrical or mechanical. But to interface to the patient, need the motivation and literature understanding from the nurse as well as patients. In terms of health technology and interaction, the literature, patient investigation, nurses and doctors. If any biomedical engineers or biomedical technician has insufficient ideas of the human body, then it makes a major problem. So we are not supposed to only run the machine as well as need the safe outcome to implement every breath. Say ECG machine or monitor or ICU ventilator. Sometimes we push rectal probe to the ICU patient. Sometimes I see that the temperature outside of the temperature, viewing the temperature, that false temperature, that time, okay, temperature is low, they are try to increase more oxygen. So we need to understand what is the tidal volume, psi function, apnea, CKMB mode, assist control mode, and everything needs to understand a clinical and biomedical engineer. We are not only liable to preventive and corrective maintenance, as well as need to understand the proper application to the patient in order to the patient's satisfaction, like my patient, what is my DHR, safe, timely, equitability, cost effective, because human wish to alive longer time. So depending on the outcome of the patient's equipments, it is in terms the outcomes of the medical equipment. So we need to address, have your country licensed biomedical equipment technician, though those are regulated publicated to the IFMB pool or Clinical Engineering Alliance. They are validated by their publication and who are giving the license in your country. Thanks.
Thank you, thank you. I think Rimi is short of time. And we are so grateful for your ideas, Dr. Anwar, and yeah, I think that will be a very good way of looking at it, like having the biomedical engineers licensed going forward, yeah. But in most of the African countries, the licensing of biomedical engineers is something that is still very low, and we are pursuing it in various capacities to ensure that we have this done. But thank you for the initiative, we're really grateful. Yeah. Please do, thank you.
Thank you, Millicent. And yes, we are improving, and there are lots of things that we need still improvements. So next, I would like to call Umetsi Francine from Rwanda. So sorry that he is not present here. So next I would like to call Igado Diaz Claudio Merovich and Julian Rotary.
Thank you. Right. Okay, right? Okay. Thank you, the organizers. Thank you all colleagues for attending this presentation. My name is Edgardo Diaz from Argentina. I am biomedical engineer since 2000. I'm medical gas specialist. I work for mid-range consultancy firm. And now I will share with you next an experience that we made during COVID-19 pandemic. Next. Oh, okay. No. Second. Yes, this is. Let me introduce the team. This is Claudio, CEO of Major Consultancy Firm. He is biomedical engineer too, from Spain. Julian Rotary is mechanical and biomedical engineer and part of the WHO team consultancy team from Moldova. So I would like to share the objectives for this presentation. First, share with you pictures for our findings during pandemic, during all this work along the countries, and then show the template that we use, sharing the content and evolution of this tool, and finally summarize the work done during pandemic, highlighting the important topics that we use as an experience. As you know, depending on hospital and countries, you can find issues and challenges in many ways. So I would like to share with you pictures by topics or maybe with by group of issues. Source, oxygen sources. Here you can see, as mentioned before, purity of PSA plants. Working around the hospital involved in these projects, we found a lot of PSA plant without low purity level. Then, cylinder manifold with fire incidents and safety concern. Oil and heat presence in oxygen sources, or in this case, cylinder manifold sources. This is an important topic because I know that the installer performance is a hot point in installation in network, oxygen network piping. So I found many focal points in piping for this kind of work without standards. This is another picture from this finds. Cylinder transportation from warehouse to cylinder warehouse to all places into the hospitals, and safety concern in terms of the single unit to attend a patient treatment. Waste in overloaded spaces in maintenance rooms. Ice presence, this is usual, but when COVID-19 strike, the oxygen demand increased a lot, and oxygen, ice in vaporizers and ice in manifold is currently. Pressure management and electrical overheating by concentrator using. Standard in bedhead units and oxygen control. Last two slides present same issues that presenter before mentioned. This is the way that we can manage calculation with data collecting from hospitals, and we suggest the amount of oxygen that is needed, and a selection of PSA plan by production capacities. Single plans according to facilities, all of this helps in our work. Okay, now we know the attention of the issues. As a background, you know that COVID impact in oxygen in high levels. So in this case, from Balkan, Asia, and Africa request our assistance. Now we build a comprehensive process to collect information, understand information, and get back again to get impact with the solution or with the assessment to these countries. As a first step, we select information by group, by topic, depending on the issue. You know that the oxygen network has start in oxygen rooms and ends in the oxygen outlet in front of patients. So grouping the information and given a standard way to process the information by each Ministry of Health made easy the way that feedback to us. A customized report, a customized solution, a work required to focus on the single hospital and give them a quick response depending on the issue that we needed. Firstly, we began collecting information from COVID official website to get a picture of the crucial scenario that we are challenging. Then WHO helped us with the first template that has information by country, oxygen sources, outlets, distribution of pipes, and hospital complexity, and finally the relationship between suppliers and each hospital. So to get additional information about that, a field engineer on each country walk around and take pictures and meetings and collect crucial information to feedback. This is the first template from WHO in 2020. Now, there are a new version in multiple languages available for additional information to facilitate the understanding among technical community. As a second step, when the information came, a medical specialist analyzed the information and made suggestions about size dimensioning in oxygen sources, in piping, in outlets, in any kind of impact, in any kind of part of clinical services. As a team, we work with a WHO technical representative, Merovich Consulting technical assessors, field service engineer, and client representative too. Together, we craft technical solutions or technical assessment based on grounded evidence. This is a big picture with all activities that we made during the whole project. So, as an important milestone for this work was that there is now a technical role by each hospital that we assessed. This guy, this manager, this technical manager, now has training, information, and they address deviation, technical deviation, and suggest training for physicians or for executive personnel, or maybe we can contact directly manufacturers, suppliers, and consultants too. All this information, standards and safety documents and technical recording are part of the quality assurance department. Plans and diagrams are open to start a new program, a new project based on updated information. Now I would like to share which countries were involved in this work. Ukraine, Azerbaijan, and Moldova have the same challenges addressed by the WHO, and we collaborate with them. In the bubble, you can see which hospital belong to each country, and the project kick off. Montenegro, North Macedonia, and Armenia were other countries that we share with WHO, and the Gambia and Uzbekistan shown as a special feature or special characteristic depending on cultural and geographical characteristics indeed. So in this case, customized reports were done especially. If we need to talk about the outcomes, we split them into direct result were a rapid inventory template, the use of this template that I mentioned before, as the unique way to collect information as a standard. In this case, 50 hospitals, more than 50 hospitals were assessed in 6 countries. In average, 3 to 4 weeks from where the quick response from each country, and the rapid feedback from our side, 2 weeks. As collateral result, we can say that now there is engineer or technical personnel training to address locally the oxygen issues with background, with document recording and special information by WHO or by our side to support them. In this case, I would mention that special thanks to representative for PATH, CHAI, WHO, UNDP, that let us participate in international oxygen worldwide team, in discussions, in meetings, and evaluating technical documents that now are available for all community around the world. So this is all. This is an experience, and I am able for any question. Thank you. Thank you.
Very nice presentation and appreciation. You are a good guy and experienced person. The oxygen generate two systems. One is PSA and another is BSA. Usually, many lower resources countries or lower income countries using PSA. Some arguments, what is the potential difference between PSA and BSA? My questions from your end. What is the advantage and disadvantages? Pressure, swing, absorption.
Pressure in absorption,
And
vacuum.
another BSA.
BSA or BIE?
BSA.
BSE.
BSA.
Okay.
Another VIE. So three tier. We can generate the oxygen from environment. Another is backup in hospital BI. So two system, which is more good and cost effective? My questions.
This is the question.
Yes.
You have two systems, PSA plant and
So
BIE.
we have option,
Okay.
so PSA plant
Okay.
or VSA plant or VIE plant. Number one question, which is cost effective, users friendly?
Okay, I don't know if I understand well the question, but if you have to address the issue that which is the best unit to support the hospital as a main source instead of PSA plant and BIE, vacuum isolate evaporation system, we can say that all of these colleagues knows that one is by adsorption process, and the other one is by liquefaction of the air. So, in the second way, I know both of them, but the second one is depending of the supplier. If you are located in the area without supplier with supplier assistance, you not another option to PSA plant or BSA plant. But in case you can do it by liquid oxygen, maybe it could solve mainly the lot of issues that the PSA plant could address to you.
Okay, thank you. Another arising question. We are using, when the PSA generator, there is a lot of electrical and mechanical devices, has a chance to control the RPM to generate. As we know, 21% oxygen from environment, natural, 78% nitrogen, and remaining percent argon, krypton, xenon, like that include. And what is the performance outcome? The purity of the oxygen from your PSA system. Number one question. And for ensure the purity, compressed air come, there is some filter, and delivery some filter. So how many times, what is the ppm of planning to ensure the quality of the oxygen delivered to the inpatient, those are admitted in the hospital, ICU, CCU, and cardiac surgery?
Okay.
What was the quality?
The quality is based on international pharmacopoeia for those countries that apply to them, and the other countries need to standard their own quality levels.
So I need to understand, you have good engineer, team is there. As it is my knowledge, I know, if many trees, then they deliver the oxygen. Say one city is no tree, natural. So what is how quality of the oxygen? Here is a dust area.
Yes, when we talk about quality, it's a large topic because depending on the baseline that you are talking about. If you are talking about a hospital in the middle of Africa or in the middle of the country without suppliers, oxygen suppliers, it's a base. If you are talking about quality standards or quality program in the middle of, I don't know, for instance, Argentina or United States or Europe, where we had more than 2 or 3 liquid oxygen supplier, it's other kind of problem. So depending on which area you are talking about, and you need to focalize them, the quality program.
Okay, thank you very much for your nice presentation. Encourage youngest, dynamic, sincere, and dedicated engineer globally. And I worked with you several times on mailing. So we need to understand oxygen generator, use, and then liquid form, and that direct form to others. A lot of pipe and junction. We need to ensure the quality by applying clinical biomedical engineering methodology to deliver the patient purity. To ensure the purity, need to see the RPM of the generator and filters, many bacteria filters and HEPA filters is using. So we need to deliver the oxygen with temperature, humidity control. Otherwise, our design and innovation will not bring good impact in our patient services. Thanks.
Thank you.
Thank you.
Thank you, all of you. Thank you.
Thank you so much, Claudio. And thank you, Anwar, for discussion. So thank you for your question also. And of course, Anwar has so much experience from the ground level, and he is very much involved in maintenance. So he knows very much about the maintenance and all. So maybe he will share his other technical knowledge later on. We will have, I think, more time because we don't have 2 presenters here available. So we are skipping 2 presentations here. So now I would like to call from Malawi to present on building capacity to strengthen medical oxygen security. So the floor is yours now.
Hello, can everybody hear me? I'm Andrew Johnston. I'm the Director of Medical Oxygen Education and Training at Build Health International. And with me is Theogen.
Yes, I'm Theogen Ngirishuti from Rwanda, and I'm the Global Health Program Manager at Build Health International. And I'm here with my colleague.
I'm Steve. Some people, they call me Grandpa Steve, or Oxygen Grandpa.
And Steve is a very experienced biomed from Malawi. So that's us. That's our oxygen team, and there are a lot more people at BHI working on oxygen, but this is the people involved directly in this presentation. So, basically, we're in a situation where oxygen is very underprovided in low and middle income countries. There's been increased investment since COVID-19 really showed that increasing the amount of PSA plants on site is very urgent. This equipment is often complex and different from what the biomeds on site are used to working with. And so this is due to technical things like powerful 3-stage motors and oil-free high-pressure booster compressors in particular. As a result, there's a very large gap in knowledge and skills between what the technicians, the engineers, and the plant operators have on site and what is necessary to keep that PSA plant going well over time. And also what we're finding is the commercial service contracts and warranties don't necessarily meet the needs that we're experiencing on the ground. And so as a result, even if a plant has a service contract in place, it may still be down. So these are serious issues that we're seeing in medical oxygen landscape post-COVID. So the goals of our projects, of our oxygen capacity building effort really is to ensure that the plants keep working. What we're seeking to do is to train the staff on hand to maintain the PSA plants at the hospital level, as well as Ministry of Health Management, then Ministry of Health managers at the national level, at the provincial level, and down to the hospital leadership to maintain these plants properly across time. As a result, we've built up a program that really focuses on this and has maintenance training for the plant operators and technicians, management training for senior managers about procurement of parts and human resource management and electrical infrastructure and service contract management, and then advanced training in TOT where appropriate. And Rana from Nepal was in the room a bit earlier. We worked with him last year in December on a really nice TOT in Nepal. Why is BHI involved in this? Okay, so BHI is Build Health International, and we're a US-based architecture, engineering, and construction NGO focused on the improvement of health infrastructure. Right? So we build hospitals, we do design, we do hospital construction of laboratories and clinics, and so we'd been working in the oxygen space through building hospitals for our partners for over 10 years. And as a result, we became very experienced with identifying and determining what PSA plant is right for what hospital, and then doing maintenance and repairs on plants for our partners. And when the pandemic came along, we had a lot of experience in PSA plants, in oxygen piping, in oxygen delivery systems, and the oxygen program became a standalone program where we're really trying to achieve scale and support people. And we have a long track record of working closely with hospital management, clinicians, communities, health NGOs, ministries of health to either help in the prior to procurement stage of advisory. Last year I visited 10 countries as part of the pre-procurement assessment of PSA plants, and Steve and Theo also logged a lot of travel miles doing those trips. And then we've done programs called Find and Fix of repair, assessment and repair of existing plants, where we've learned a lot about how to repair PSA plants and how things go wrong in a lot of different contexts. And then we moved to training to really address this on a sustainable basis and to respond to the fact that so many PSA plants are coming into the countries that we need to do what we can to keep them going sustainably. Where we work, BHI started in Haiti through the construction of a 300-bed teaching hospital that opened in 2013. And now we work in low and middle income countries, mostly in Africa, but also in South America. And we've done a good bit of oxygen advisory and training in Asia. On to Theo.
Thank you. Thank you so much, Andrew. And so the question is, why do we train? We have seen that in most of countries where we have been, we have seen that biomedical engineers and technicians do not have adequate knowledge to manage and operate these PSA plants. And therefore, in many situations, some PSA plants really lie idle, or they are not producing oxygen to their full capacity. And in other countries, we have seen that the senior leadership from the ministries of health and other decision makers are really not prepared to integrate PSA plant in their health systems. And therefore, this has led to serious breakdown in the spare part supply chain. And this has very drastic consequences which can cost lives or can affect the quality of care that we give to our patients. And then we have realized that by the fact that PSA plants have components that are not in other medical equipment, their maintenance really become very, very difficult and challenging. And we have realized historical and notorious neglect of the management and maintenance of systems. And this has led to, certain level of relying on expensive contract or expensive sources of oxygen. And it has led to inabilities to perform maintenance in different ways. And, but the most important thing that we have realized is that those who are the institutions who have trained biomedical engineers, they are able to address their problems. And these problems include underperformance of PSA plants. They include the management of service contracts, and they are able to continue to sustainably maintain their PSA plants when the service contracts end. So what is our approach? When we are training, we first of all give a detailed theoretical understanding of the principles of PSA plants, and then we go to different sites so that the technicians really have hands-on experience of what happens on PSA plants. And then to ensure that there is learning, we have pre-training, daily, and post-training assessment. And the most important thing we do is to sit together with biomedical engineers to create daily checklist and preventative maintenance plan for their specific plants. So this really help to, to engage them, and then they adapt the materials that we have to their own situation. And when we finish the training, that's not the end. In fact, it is the beginning, because we create an online community where we continuously support different communities answering their questions. So we have 3 types of training, and the first one is the management training, which require no prior knowledge. Anyone who is in senior leadership can attend and benefit from it. And our main objective in this training is really to ensure that the senior leadership are fully briefed. They have enough information to make adequate decisions in integrating PSA plant in their health system. And then we have the maintenance training, which is a 5-day intensive training for biomedical engineers, technicians, facility managers, and hospital operators, the people who work on PSA plant daily. And our objective is to make sure that they are familiar with their PSA plant. They can operate it, they can maintain it, and most importantly, they can fill the daily checklists to monitor, continuously monitor the life of their PSA plant and address the problems as soon as they appear. And then we have the advanced training, which is for experienced biomedical engineers, and we train them to train others. And the objective is that these experienced senior biomedical engineers can pass their knowledge to the next generation. So we are trying to build a linkage between different generations, and while doing that, we hope that there will be a continuous supply of oxygen in different facilities. Steve.
Yes. So I think Theo just forgot something that we normally give when we are doing the trainings.
Okay, so Steve has reminded me of the cashier or something that characterized our trainings. And this is really having oxygen in our blood as we train. And I would like to invite all of you to just stand.
It's close to lunch. We want to wake you up. Close to lunch.
Just accept to stand.
Can we all stand up?
Yeah. Thank you.
Thank you so much.
Yes, so can we stretch a little bit? And we all know that without oxygen we can't live. And so I want to put in your blood, in your lungs, in your body, a certain level of oxygen. So I'm going to ask you to shout, oxygen. You shout as much as you can. Oxygen!
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 Now we are going to do it in 2 parts. We start from here, then you will follow. Oxygen!
Oxygen!
Oxygen. Okay, I think you have oxygen now. I'll pass it to Steve to continue.
All right, thank you. There's no oxygen training without oxygen. All right, so I'll take it from there. I'm just going to go through some highlights of the training. We have practical sessions, and we have assessments, and also there are materials that we are giving out after the training. Practical session, we make sure the technicians, they have a chance. We go try to find the nearest oxygen plant, and that is the practice. We show them some tricks that they can use in future. And the assessments, we have like daily assessments. Every session for 5 days, they have to write so that we know the progress. This also helps us as an indicator to see which side we are behind, which side they need more emphasis. At the very end, we give them materials. These materials, they come with a daily checklist book, a maintenance log book, and the repair log book, and also the materials that we have used for the training. At the very, very end, we give them the basic tools. We make sure these tools are not the tools that they can use to fix motorbikes or cars. So these are just specially for the repair of the oxygen plant. Now, let's go to progress. For the trains, we have at least trained more than 119. These are biomed, facility engineers, and also hospital administrators. And we have visited 14 countries, and I happen to at least 70% to 80% of those have been there. I've been to Sudan, with Andrew. The training was good, but at one time we had to turn into James Bonds, trying to make sure we are safe. And again, there's the knowledge increase level. But one thing we realize, it's after when checking the progress, we find out that from the beginning up to the end, at least there's 80% increase of knowledge. So best practices. So we have this personal training inside, which is mixed up with the theory and the practical. And also, we try to make sure we have timely coordination with the ministry. This is important mostly for us. Like you can see, like different countries, different cultures. So you need to understand the culture of that country. Make sure you have, I think someone talked about this best approach to the ministry if you want to get good results. At the very end, my friend Fio talked about this, and I heard also from the lady, she talked, I think we are using the WhatsApp. So we have WhatsApp groups from all those countries we have been visiting, which is crazy. We need to improve, we need to figure out the best way of doing that. And in this, whenever they have like problems, we share and we try to support them and also try to make sure we don't leave them alone. I think from there, I would say, let me give it back to Andrew.
Thank you, Steve.
Thank you.
And so looking ahead, what we're seeking to do is enhance our follow-up. And what we mean by that is we've tried to start communities of practice after each training so that the people that we train can stay in touch with each other and stay in touch with us. And there's also a lot of mutual accountability with that because they're supposed to share their daily checklist with us every day, starting the day after the training, which is the most important day of the training, is when they get back to their workstation and start actually putting it to work. And so we want to see the daily checklist and we want to hear if they have questions, and we follow up through that, but we're looking for a way to strengthen that with a platform that might replace WhatsApp. We're also trying to, now we're working on scripts for permanent resources in terms of parts of the training that can be filmed and put on YouTube, both the classroom sessions from the 5-day maintenance training, some of the management sessions, as well as some practical sessions. So, you know, one option is to have Steve come to your country in your PSA plant, and he can show you how to do preventative maintenance. But we're also planning on filming him work on a few different plants and to give some permanent resources that we can share out. We're looking to continue to reach more trainees through both hybrid types of training and as well as through our Rwanda Training Center, which we're building in partnership with the Rwanda Polytechnic, IPRC. I've been spending a lot of time in Rwanda this year, and we're looking forward to installing at least one PSA plant there soon, as well as there's a good bit of piping and electrical that we can train on there. One of the advantages of the training center is that we're going to be able to bring people to that training center from countries that may have security issues, and so we can't get approval to go ourselves. We can bring people there. And also for situations where a country, the smaller countries that have only one PSA plant, we may be able to do some combined trainings for the Francophone countries or for the Anglophone countries at the training center. And so that's important as well. I think also in terms of looking ahead, language is really important. And we have an English-speaking curriculum and a French-speaking curriculum. Theo and the rest of our Rwandan team have trained in Kinyarwanda in Rwanda and Kirundi in Burundi. Steve is from Malawi and really led the technical side of the training in Malawi and Chichewa, and that worked really well. We're translating our materials into Spanish right now for some Central and South American training, and exploring the option of translating into Portuguese for some of the African contexts that speak Portuguese. So those options are coming up. And also just really important, a good source of information is now the BHI Oxygen website that's up there. This launched about 2 months ago, and it's we tried to put our best available materials there, and we'll keep adding things to it. Also, please follow us on social media. And if you have a specific training request, my email's up there. And so if you'd like to explore bringing oxygen training to your hospital or to your organization, just email me and I'll get right back to you. We're around the next few days so we can talk as well. Thanks so much. Thank you. Thank you, Theo. Thank you, Steve.
Thank you. Thank you so much. Any questions for us? Comments? Suggestions on what we do? Thank you. Thank you so much.
Thank you. Thank you.
So thank you, Steve and the team, for a nice presentation. And if there is no question, then maybe we will have some more time for lunch. So, Tom, do you have any closing remark here? If you have any closing remark here for this session? Okay, then see you all in lunch. So break time. Thank you. Enjoy your lunch.
Check. So for the food, you can go to same food court area for your lunch. And again, a gentle reminder to everyone who has booked their stay through Holiday World. A simple reminder to everyone, please ensure that you meet them and make your payment. Otherwise, there will be difficulty in checking out from your hotel. So the booking payment counter is right there at the AMTZ stall. Opposite there, you will see Holiday World. Please ensure you make the payment through card or cash. Thank you.
Radiology Center, named in honor of our wonderful colleague Mario Castaneda, and several of us were a part of a celebration of his life there for a few minutes, just in the past 15 minutes. So thankful for Mario and his impact. Well, this is session C1, right after lunch, about credentialing. And I'm going to talk about global CE status. So my friends are going to put my presentation up, I hope. So this is, as it's coming up, this is our contribution of our partners, the IFMBE Clinical Engineering Division and Global Clinical Engineering Alliance, for whom I now serve as Liaison Director for GCEA. And let's see. All right, and who is on this global team that is putting together this particular presentation today? And it's Dr. Yadin David, whom you met online, Fabiola Martinez, who is, I think, in another session right now, but the chair of CED today, myself, the past chair of CED and liaison director for GCA, and Calaroy Stavriano, and she's the reason all of you are in the room, because she made it happen. Here she comes walking down the center. So the community, as I said, GCA and CED, we made a big impact on global health during COVID. I mean, that's a pretty brash statement, but let's see if, when I show you the evidence, to see if you agree with that. And Dr. David would lead and say there is a global reliance on health technologies, and I'm going to grab closer here. I'll try to imitate, but I'm not as cool as Ricardo Silva. But many people have written about the global reliance on health technologies and whose innovation and deployment and support continue to improve worldwide healthcare delivery. And, you know, WHO, the evidence started to boil up for WHO in 2007, and they wrote a resolution about the need for proper management of health technologies. And so we have captured what happened with our community during COVID, along with our partner Adriana Velazquez, who gave the keynote this morning, in an article. We talked about the status of clinical engineering worldwide in 2020 up until COVID, but at the end of last year we did what have we done since during COVID, and more of our needs for global healthcare to rely on the clinical engineers in the global community is in this article that Dr. David and I got to write in a year and a half ago. That's in the National Academy of Engineering website. And what it talks about is we need increased education, we need increased policy, we need increased alliances. So I will talk very briefly here about what we did during the pandemic, but everybody knows what was happening in the world in March of 2020. The pandemic was beginning to go worldwide. And as some of you have heard me say, Adriana, representing medical device management for the world, called Yadin and I, basically GCEA and CED, you might say, near the end of March, and said, help. And she wanted help with a couple things. China wanted to give some ventilators to the US, and she wanted a team of experts to start to get in line behind her to meet all the needs. And we were able to do that in the last 7 days of March. We launched that, and by the next week, we had the first global webinar on how clinical engineers can help combat COVID. And a month later, in May of 2020, we began a series of several webinars partnered with Adriana about clinical engineers' best practices in the midst of COVID. So that was just kind of the start. Later that year, our friends from ICEHTMC in France, representing the French-speaking world, liked our English-speaking webinars so much that they started a series in French, bringing in French-speaking countries, particularly from Europe and Africa, to drive those webinars. But, you know, that's kind of maybe the big picture, but all of you lived through it. All of you contributed to, you know, I'm looking at my friends from Build Health that were creating oxygen capability, the incredible demand for oxygen in all countries, but particularly low, middle income countries. So I don't want to say, hey, it's about us maybe in these leadership roles, blah, blah, blah. No, I'm saying clinical engineers who are on the ground. I'm looking at Bonnie from Botswana. I'm looking at Baron from Nepal. You're the ones for the global clinical engineering community that made the difference. I mean, many of you have heard the story about Baron. I'm not going to stop too long, but Baron was in ICU with his brother. There was a problem with the equipment and oxygen for his brother, and Baron solved the problem and saved his brother's life in Nepal. So, I mean, there's story after story of what you did during COVID, and we in global community leadership were cheering for you and hoping, trying to enable you in many different ways. So, and partnered with WHO and around these various webinars and best practices we were sharing was 160 countries came to our webinars. So, yeah, as I mentioned, there's a couple articles at 2020 and end of 2022 that chart all this work. And it talked about, you know, how are we going to address that? And that really is the priorities that we were talking about yesterday morning. We want to build the capacity of biomedical clinical engineers in the countries to serve more in the ways that they did during COVID. We needed to be able to measure that long-term impact. And I told the story yesterday morning of Dan Clark in UK rallying the clinical engineers in the National Health Service in UK to get accurate oxygen pulse oximeters out to the masses in his country, and thereby being able to measure at home early onset of COVID respiratory challenges so that they could get timely care and save lives, and that happened. But in this call for action, there were more things we did that were helpful. We queried you around the world. Our colleagues in 128 countries responded, nearly 900 responses, telling us what you do in your various areas. We believe that sets a pattern, a groundwork, and this is a credentialing session. We need to be able to demonstrate our competency to the rest of the world, and we believe 80% of what clinical engineers do in any country of the world is pretty common and similar, and best practices are built around that, but there's 20% differences. We want to honor those differences and help you, enable you to solve that last 20%, although we globally can maybe contribute to the 80%. So that survey at the end of 2022 really noted how to best do that. So I want to go a little bit deeper in this number one here, the education of the workforce. And one of our physician colleagues in the room, Dr. Kohli, Manish Kohli, is speaking about that in other sessions. There you are, as is Elliot and others of us. But doctors are busy. Nurses are busy. What is it that the clinical engineering community can do to help them use better, higher efficiency tools, digital health tools, and relieve them of some of the burden of the resources and equipment that they're using so that they can do direct patient care? So we're looking for collaborations with nurses, and I bet something can happen through AMTZ about that. We're looking for collaboration with physicians, and we're looking, with health administrators and so forth, and to build that collaboration into education that will change the workforce formula. I mean, one way of looking at it, and I'm parroting Dr. Kohli here, is physicians and nurses are the biggest cost in healthcare for good reason. But if we can let them do more patient care, the money will be better and will work out better, and the resource use. Yadin David would say, if you look at pictures of how healthcare is being delivered today, and I'm thinking about the pictures of the robotics for prostate cancer surgery, the engineers getting closer to the patient, the doctors moving further away from the patient as they deliver that care. So that speaks to what's going on in our profession. And where do we make an impact? Yes, we make an impact on ensuring the equipment uptime and maintenance. But, we have brain power that can be used in wider ways, like how do we optimize clinical workflow? Once again, likely using digital tools. I mean, one example from my work with Kaiser Permanente, a large healthcare system in the US for 25 years, was how doctors used to read EKGs. And they might print out paper, they might take them home, they might try to see what they said, diagnostically. And today, you can go into a patient room, take an EKG, it can be wirelessly transmitted to an electronic medical record. The medical record is connected to communication systems so that the EKG is sent out to a doctor and then another doctor to overread the other doctor. Anyway, the diagnosis can get back to the bedside in minutes, where it used to take days. I mean, that's just one of a gazillion examples. So, I'm trying to get to the next slide. There we go. And we talked yesterday morning about national policy. What we'd like to talk about is, has the profession grown in credibility at the highest levels? And our response to that is, we talked about what happened in March and April and May 2020 with our webinars. Also in May 2020 was the and some of the words are failing me here, but the executive committee, the ministers of health of 194 countries normally gathered every May in Geneva to analyze problems and issues. And you can imagine what was on their mind in May of 2020, just after COVID was hitting. They said they had about 3 top issues, and this is prime ministers of countries and ministers of health of countries gathering together virtually because COVID didn't allow them to get together face-to-face like they normally did. But they said, we need ventilators. That was one of their top 3 issues. And they pointed to Adriana's unit in WHO in Geneva to help drive change and access to ventilators. And we all know what happened with ventilators. A lot of countries wanted to build their own, and that's good. But they had to meet quality standards, of course, and they had to not only deliver technical performance, but had to be able to impact clinical performance while meeting regulatory requirements. And so, you know, one of the things that happened was emergency use authorizations, EAUs, that allowed many ventilators to be built and applied to the population. In fact, 3 different kinds of ventilators met EUAs here in India through AMTZ, and so they were able to manufacture, as you heard Jitendra say in his keynote yesterday morning, thousands daily to impact their country. So national health policy, so the next year when the same ministers of health met, the question was, we need oxygen. And, you know, and we've all been working on that. Many of you worked on that. You know, there's people here, I know Millicent in Kenya and Deborah in Uganda, and many others have been working on solving oxygen challenges like it's been done in Malawi and been done in Chad and DRC. My point is, they again pointed to Adriana's department to work on that. They also pointed to her for digital health tools, for PPE. And when I talk about oxygen, just not just oxygen concentrators and ventilators, but also oxygen sources. So the scope of practice and the scope of credibility increased. And the session chair is telling me to hurry up because I think I'm done with my time here. Oh, I'm the session chair, okay. But anyway, so national health policy can drive that, and Jitendra has been a champion for national health policy in India. People like Fabiola with the SOMIB National CE organization in Mexico have been a champion. Our sister Tazeen Bukhari in Pakistan, sorry she couldn't make it, I won't talk politics. Pakistan, okay. But has won the right to serve with Ministry of Health and WHO in Pakistan. Those are success stories. So we need to be more involved in policy. And then, you know, I talked about yesterday morning and yesterday night with Yadin and friends about what the Global Alliance is creating, many alliances with a variety of groups, the HTA group, with CED, with countries. So we need to work together more and more. I showed this before. We created a framework for capacity building, knowledge, investment, and competencies. That's a little bit of the survey data. And what you need to see is red means a low middle income country as defined by the World Bank. And then you can just see across all the 6 WHO regions of the world, there was great involvement by many countries. And the survey said, here's the priorities of what we need to work on country by country. We've started to do that with this Congress and in many other ways. And I'm done. Thank you very much. Maladen, not yet? Maladen Paluta now or later? Put him up. We're delighted to hear next from our GCEA colleague and President-elect, Maladen Paluta from South Africa. So Maladen's video will run now.
This quote from the 2010 United Nations Summit clearly underlines the need to look beyond the healthcare system in addressing the disease burden. Indeed, people do not live their lives in ancestors. They live in communities and we need to connect the dots with community wellness as a goal. 2 years later, the World Bank released a public health policy note that shows the interconnectedness of other sectors with and impact on the health sector as part of a broader health system. This slide, coming from the landmark Alma Ata Declaration on Essentially Primary Health Care, emphasizes the importance of health-related technology and infrastructure, such as that associated with provision of safe drinking water and basic sanitation as contributors to community wellness. Here we see a mapping of the diverse health-related technologies and infrastructure linked to health interventions on the right and public health interventions on the left. The holy grail needs to be managed in an integrated way in support of community wellness. Maintenance of health-related engineering assets within this broader health system is clearly needed, but maintenance failures at the transversal connector face major challenges in many countries, including lack of career opportunities and poor supporting infrastructure, exacerbated by government department siloed inefficiencies. In the healthcare space, this is not the least relevant. WHO's 1987 Global Action Plan identified these 4 obstacles, very similar to the challenges faced currently. So, if we knew what needs to be done 30 years ago, why are we still in a similar situation, and possibly worse, as evidenced by this example? From an East African case study indicating that only a quarter of the available pool of clinical engineers and technicians are practicing as such, while the skills pool is still being added to with new entrants. The silver lining of this large chart is that there is a significant pool of underutilized technical skills available for upgrade and deployment under a different strategy, such as that proposed. Uniting the health-related maintenance tables carries a number of significant advantages, not least removing siloed inefficiencies and duplicated systems, while benefiting from interdependencies, including development of both generic and specialized skills and capabilities. This will also enable a common standardized approach to lifecycle management of engineering assets, as set out by the ISO 55000 series of standards that also correlate closely with health technology management and clinical engineering. Of course, an enabling environment, including an integrated asset management and maintenance system, and tele-maintenance solutions in support of a unified structure, will have to be in place if the efficiency gains and other advantages are to be realized. So in conclusion, it's my contention that such a multi-sectoral maintenance-related initiative is more likely to receive adequate and sustained funding from stakeholders. It will have the added benefit of strengthening existing clinical engineering structures and capability. The new cadre of health systems engineers will need to be engaged to engage with the broader health system stakeholders, providing new opportunities for clinical engineering practitioners, especially in low and middle-income countries. This initiative will also lead to greater societal
Thank you so much, Mladen. We are doing one-way live streaming, so he might be listening, hey Mladen, but we cannot question him right now. But I'll remind us, and by the way, we're doing great on schedule here, so I'll take a minute before the next speaker. So this is the credentialing track, as you well know. What does credentialing mean? In some parts of the world, it means registration of engineers, biomedical engineers, clinical engineers, but most of the time, for most of us, it means certification. And we've talked in this Congress about certification of clinical engineers as we've historically known them. We've talked a little bit about certification of clinical engineers with digital health, otherwise known as CEIT certification. So I talked about what's the status of clinical engineers before and after COVID, and we were called upon and we displayed some certain competencies during COVID that's given more attention on our profession, and we want to bring this. We want to bring recognition, but we also want to be able to measure competency. So a minister of health, if he wanted to build up his cadre of clinical engineers and other related technicians and others, and perhaps give physicians more capability related to the management of health technologies, as we see with certain physicians in the room here right now, Dr. Mayombe, Dr. Coley, and many others. How do we give competency credentialing, like physicians and nurses and nurse practitioners get credentialing, and physician assistants and midwives? How can we bring that kind of credentialing formality? And one answer is, before lunch, I was in the speaker lounge with that guy that walks around here, Jitendra Sharma? Yeah, Dr. Sharma, who runs AMTZ, and he was showing me a picture in that room. There's the India Biomedical, it's IBSC. I'll probably remember what the S is here in a moment, but skills, there we go. India Biomedical Skills Council, and there's 5 different kind of certifications. Thank you, brain fade, I'm older. Anyway, and I know they certified 1,300 practitioners in the years before COVID, and maybe some of those certified practitioners are in the room, and there was 5 different kind of certifications, but clinical engineering and biomedical equipment technicians being 2 of the 5. I think the other were project management, manufacturing, and don't tell me quality. But my point is, so what has the global clinical engineering community been trying to do? We've been trying to we wanted to certify the certifiers. We didn't want to run a certification program for your country where, even though 80% of what you do might be what we do in every country of the world, you have that 20% that maybe is unique to your country, but we want your country to certify its practitioners, but to be recognized globally. So we want to help certify those certifying bodies, if that makes sense. And what Jitendra was showing me was a picture of that their IBSC program is now accredited by the International Accreditation Forum, IAF. And maybe that's a silver bullet for our profession, that if we can get recognized by that accrediting body, then we can go about the business of helping you get your certifying bodies, which will allow recognition of the profession and a competency training package and testing package, evaluation package, such that you can get jobs in any country of the world, but get the best jobs in your own country. So part of what I'm saying is we've been working on credentialing for a long time, but I think we're closer to solutions that we all want than we've ever been. So, but there's other things about credentialing that are worth knowing, and one of those is Lori Warren's from the US, and so we'll hear more about that. So while that's come, oh, there it is, so I'll shut up.
The MSA, Science, was formed in 2012 when about 70 And it's now becoming a benchmark for the clinical trial community to do this. And then engaging MSROs. We have MSROs who have become accredited, and then others who have said, we'd like to, but we need support. So this year we're working on a Pathways to Accreditation program to help build capacity across the system. So in closing, I'd like to say, we know from our research and from statements by multilaterals and leaders in this, that medical device donations in low resource settings and medical supplies in general, it's frequent, and it's a strategy that can help strengthen healthcare and improve outcomes if it's done properly. So we identified that also that there was agreement that it was very important to increase awareness of device guidelines and to help build capacity again across these systems to meet these guidelines. So our approach is to address this challenge and to ultimately benefit clinical care providers and patients in our work. And I wanted to be here today in part to communicate what we're doing, but also to invite you to engage with us. We would love your input, your suggestions, your comments, and I hope I can hear from you, and I'll answer your questions at any time. Thank you very much again for this opportunity. You can contact me at L. Warrens at the Task Force for Global Health, or visit our website, taskforce.org, for links to learn more about the program and to contact me or anyone at the task force. And again, thank you so much for this opportunity to be here today. It's been a pleasure.
So, donations, ever been a problem for you? The answer is heck yes. Big problem. So this, Lori Warrens happens to live in my home city, Atlanta, Georgia, USA, Georgia Institute of Technology, otherwise known as Georgia Tech, but there's several global healthcare organizations out of Atlanta, like there are other cities, but it's one of those area of strategic NGOs, non-governmental organizations, nonprofits. And we all know there's well-intentioned people, well-intentioned health systems that donate to various places. Once again, Debbie in Uganda and I had a story about Kampala and Makerere University, in a very outstanding health system in North Carolina in the U.S. Don't need to name names, but the donors don't always know within their organization that they're giving same things that the next department over is giving. And it ends up in graveyards, and it burdens LMICs with inappropriate donations. But this is forcing those that give to follow guidelines and make sure they think system-wide, comprehensively, in the way that we have to. And so that's another area that needs credentialing to make sure they're meeting performance standards and have the right competencies. So, of course, it's a little embarrassing that I couldn't think of, India Biomedical Skills Council, since they're going to give after one more presenter, they're going to present their incredible program here in India that was being built 5 years ago when I was here for the 4th Global Forum on Medical Devices with Adriana and friends and Fabiola and others. So we're going to come back to the people side after this next presentation. We're coming back to IBSC because the next presentation from Canada, Mayange Janvier, Andrew Ibe, and their colleague Yinyu are going to talk about clinical engineering, I believe, clinical engineering department accreditation. So take it away, Canada.
Hello, everybody. My talk today is about enhancing accessibility and inclusivity in clinical engineering certification using the virtual exam accommodations and guidelines. My name is Mayange Janvier, and my teamwork are the Canadian Board of Examiners for Clinical Engineering Certification Executives, which I'm the past chair. The current chair is Andrew Ibe, and the chair-elect is Yun Rachel Zhang.
And I'm wrong again. This is about people certification.
The description of this is that as the field of clinical engineering certification continues to evolve, it is crucial to adapt examination processes to ensure accessibility and inclusivity for all candidates. This study focuses on the Canadian Board of Examiners for Clinical Engineering Certification and their efforts to implement virtual exam accommodations and guidelines during the COVID-19 pandemic. By transitioning from in-person exams to a virtual format, the Canadian Board of Examiners aims to address financial, travel, and health-related constraints while maintaining the integrity of the certification process. This paper presents the guidelines developed by the Canadian Board of Examiners to facilitate virtual oral exams. Ensuring a fair, efficient, and secure examination experience, the guidelines outline communication channels between the Canadian Board of Examiners, candidates, and potential proctors, along with the selection and preparation of suitable locations for the virtual exam. Furthermore, the study examines the strategies employed by the Canadian Board of Examiners to enhance accessibility and inclusivity during the certification process. It explores technological infrastructure enhancements, security measures, and considerations for candidates with disabilities or specific needs. The Canadian Board of Examiners also extended the validity period of certification, provided online training, resources, and utilized virtual platforms for continuing education and professional development opportunities. The results of these guidelines are presented here, where we look at the priority of accommodation. If an accommodation is offered, the board will offer the oral exam in the following priority of sequence. The first option is an in-person during the annual conference of the Canadian Medical and Biomedical Engineering Conference. The second option is a hybrid, where we have one examiner is present in person with the candidate and one examiner is present online. The third option is online, where the candidate is present with one proctor in person and two examiners online. Option 2 and option 3 are provided normally 6 to 8 weeks after the annual conference of the Canadian Medical Biomedical Engineering Conference. If there's a retest that needs to be done, usually this is provided during in an in-person retest. The location for the virtual exam is usually the Canadian board will notify the candidate if they're able to secure a location for oral exams in the candidate's area. If Canadian board is not able to secure a location for the candidate is responsible to select a location that is comfortable and free of distractions, noise, people, and to conduct a virtual oral exam. It shall not be the candidate's home. Healthcare professional setting is preferred where there is internet access to sustain at least 3 hours of continuous video conferencing. The candidate is responsible for communicating the location and any related information to the Healthcare Technology Certification Commission, HTCC, via the Secretariat. The board will review the location for accessibility. For the proctor, the board will appoint a proctor to supervise the virtual exam if both examiners are not physically able to be present. The minimum requirement is that they must have an engineering or professional background, and the proctor should not be a future candidate considering a clinical engineering certification. Ideally, it should be a certified clinical engineer. If there is any conflict of interest or the candidate has concern with the selected proctor, the candidate can propose an alternative proctor in accordance with the minimum requirements for the proctoring role. The candidate must communicate the proctor selection to the board via the Secretariat for consideration and approval. The proctor will need to declare any conflict of interest and sign the non-disclosure agreement in advance. Alternatively, if a proctor is deemed non-required by the two virtual examiners because of an alternate method of surveillance is available or other valid reasons, the selected proctor can be excused. The board will communicate this information to the candidate, and the 2021 rules of alternate format oral exam from the clinical engineering certification of the US will be followed in this case. What is the role of the proctor? The proctor will maintain silence throughout the virtual oral examination procedure. Any discussion with a candidate will be a violation of the virtual oral exam process. Both virtual examiners will read from a script that will not be made available to the proctor. The proctor will have to follow the script from their own electronic device. The proctor is prohibited to have any discussion with the candidate about the examination process or result, that is, provide impression of exam or judgment of result. Any discussion will be considered a violation of the virtual oral exam process and may result in forfeiture of the oral exam results. The proctor is responsible to indicate or confirm any environmental or utility system or network issues that occur during the exam. Furthermore, they might be contacted by the board to verify any issue that occurred during the examination administration. Examiners. Examiners are required to test their method of video conferencing prior to the virtual oral exam and the platform used, and test the platform used, either Zoom or MS Teams. Examiners are encouraged to read the current Healthcare Technology Certification Commission Certification of Clinical Engineering Handbook to ensure the rules of an oral examination are followed. Examiners must decide on how they will coordinate and keep track of their time during the virtual oral examination process. Role of the examiners. A full view of the candidate's face should be made available during the video conferencing period with no covering of the mouth. An audio test should be performed by the examiners before the oral exam to make sure the candidate can hear them properly and vice versa. Examiners are required to follow the script of the oral examination and understand each part of the process. Scenarios are to be made visible to the candidate on their computer screen for the full 40 minutes allocated for notes during virtual examination. The scenarios are to be kept on the screen after 40 minutes for the entire virtual oral exam session. It must be clear to the candidate that their notes will remain with the candidate throughout the exam and they may refer to them at any time. Continuing of the role of the examiners, examiners may request silence in the virtual oral exam during the period of the examiners are taking notes. Violation of this request will be considered a violation of the virtual oral exam process. Examiners are to mark the answers of the candidate on the oral exam sheets. It is recommended to take notes verbatim of the candidate's answer to each question. Marking is performed based on the candidate's answer to all the required points in the question. A grid is provided on the oral exam sheet for the examiners to follow and use in their judgment. Examiners are to debrief right after the virtual oral examination. Examiners are to notify the results to the board. The Canadian Board of Examiners are to vote on the results of the candidate for the virtual oral exam. If a candidate oral virtual exam results in a fail, a debrief meeting should be organized with the Canadian Board of Examiners where both examiners discuss the results. Once the results have been voted on, the board are to send the results to the HTCC Secretariat. Shadowing for training purposes. The shadowing or virtual oral examination is possible with the virtual oral exam. Maximum of 2 members from the Canadian Board of Examiners are permitted to attend a virtual exams for training purposes. The HTCC Secretariat will send a notification to the candidate asking permission to have the presence of trainees in their virtual oral exam. If approved by the candidate, the shadowing members of trainees are allowed to participate virtually in the oral exam and a debrief session of the oral examiners. Shadowing members or trainees must be muted with their camera off during the virtual oral examination process of the candidate. In addition, shadowing members should take notes of their assessment of the oral examination administration of the examiners for their records for quality improvements. If not approved by the candidate, no shadowing members or trainees are permitted into the virtual oral examination. If there is one technology glitch during the virtual oral examination, candidates are provided extra time to supplement their lost time during the oral exam. If technology glitches persist multiple times, the examiners, proctor, and candidate will resume the oral exam via teleconference. Phone numbers should be exchanged in advance to ensure a seamless transition should this situation occur. If this option is not possible, the board will review this case and decide how to defer the exam to a different date and time. Appeals will be handled as per the current CCE handbook. So by analyzing the adaptations made by the Canadian Board of Examiners, these studies shed light on innovative approaches to clinical engineering certification. The finding contributes to the ongoing development of resilient certification methods and provide valuable insights for certification bodies and professionals in the field. Understanding and sharing these best practices will enhance preparedness for future disruptions and ensure that certification processes remain inclusive and accessible to all candidates. Thank you.
A wonderful piece of work from Mayan Janvier there from Canada about clinical engineering certification there. And so that's one of the models of certification. I'm going to talk a little bit more about it. It's the North American model, really, with Canada and the US. And of course, our next presentation with our IBSC folks from India will be another model of certification. There's probably about 5 of them around the world that are particularly notable. In this one, some things that didn't get said is that, all right, so 1979, I'll just give the quick personal story. I started my role as a clinical engineer. I had to have 3 years of experience before I could consider taking the certification exam in this North American model. So in 1982, I did choose to, and the process was I had to take a written exam across, that 80% of content I talk about, and then the 20% that was maybe unique to the United States. And if I passed the written exam with a certain level, and I won't embarrass myself and tell you how close that was, but then I got the option of taking an oral exam, typically an hour with a couple examiners. And we were able, back in that day, we could meet every year at the AAMI meeting, one of our co-sponsors of this Congress, Association of Advancement of Medical Instrumentation there in the Washington, D.C. area, that has worked very closely with our field and works with the Food and Drug Administration in the U.S. and works with standards for medical devices around the world, a very important organization. But so we were able to go to face-to-face meetings. What I love about the Canada variation of that North American model is that, hey, during COVID, we can't meet, or, Zoom is out there today. Why can't we meet, online and run a process according to good, strict criteria, but and then have somebody oversee the process, the proctor. And so it's a valuable approach, and they've been very successful in Canada with that approach, and I applaud them. So without further ado, I call up India Biomedical Skills Consortium. Take it away, sir.
Yeah. Good afternoon. Myself, Naresh Kumar. I am a biomedical engineer. And in India, we have just only 140 engineering colleges is offering the biomedical engineering course, and just only 30 colleges offering the diploma course. Approximately only 6,000 professionals were doing the education, and they are practicing the biomedical engineering profession. This is the one side of the traditional education system. However, there is no training institutions in India where the candidates will get the quality training, and also the certifications. Certifications is very, very important. It's not just like some training institution certification, accreditation certification. So to give the solution, AMTZ is created in a system. It's a certification for the biomedical engineers. It's an Indian Biomedical Skill Consortium. It's our team, myself, Naresh Kumar. I'm a biomedical engineer by qualification, and we have 3 senior trainers available with 20 years of experience, and our head HOD, Jeena sir, and the chairman for the IBSC is Jitendra Sharma sir. And we have the certifications programs. These are accredited by the Ministry of the Skill Development and Entrepreneurship. We have programs, CBME, Certificate in Biomedical Engineering, Biomedical Manufacturing, Biomedical Quality Assurance, and Project Management. We offer the training programs to the students, for the working professionals, for the skilling and the upskilling programs. For the students, We have the multiple programs at different levels. Level 1 is for the focuses on the critical care equipment. Level 2 is focuses on the operation theater equipment. Level 3 is on the radiology equipment. Level 4 is for the laboratory equipment, and level 5 is the testing and calibration of the medical equipments. These are the technical trainings where during the education, the candidates will get the only traditional academic background only, without any practical knowledge. So we at IBSC, we are giving the practical training to the students on the demonstration and troubleshooting of the medical equipments. So each program, these levels L1, L2 and L3, L4 is clubbed together again a certificate in biomedical engineering. This program is for the students and the graduate students to help the employment opportunities in the hospital as a clinical biomedical engineering, and in the manufacturing sector, and in the companies as a sales engineer and the service engineer. These 5 job roles we are preparing the candidates. And the other program is the certificate in biomedical maintenance program. The maintenance program is for the those who are already working in the company or in the hospital without any formal trainings. They may be a junior level engineers who are working already in the hospital. They have in the hundreds of equipments, but they don't know that how to troubleshoot the equipment, how to do the preventive maintenance of the equipment. So we are giving the online training program to such working professionals during the weekend. So they are doing the upskilling their profession. And we have the other program is there that is called Certificate in the Biomedical Quality Assurance. This program is also for the working professionals, focuses on the medical device regulatory affairs. In 2020 to 2016, there is a Indian Medical Device Regulation is there Act, where the medical devices are under regulation. So we are training the workforce in this area. And we have the other program that is certificate in the radiology equipment service training program. This is the only program in India. We are offering the X-ray repair equipment maintenance of the X-ray missions. In India, lakhs of equipments are there. X-ray missions is installed, and there is no training institutions they are offering the service training program in this area. And we have the other programs which are supported by the Government of India under Department of Biotechnology Skill Vignan scheme. In this program, the candidates will get the financial support. The same hands-on training on the medical equipment certificate in biomedical engineering program. They will get the 3 months training program with the stipend support. And the faculty development programs also we are offering in the various segments like the materials testing, hands-on equipment on the medical equipment, and the EMC, MI testing, and various programs we are offering. And entrepreneurship development program is another program under Skill Vignan grant, where we are giving the training on the entrepreneurship development skills. It's a 6 months duration, and with the financial support, after completing this 6 months training program, the candidate is going to start the startup company. This is now, as of now, we are conducting these programs. We are upgrading these programs to the academic programs. As of now, the programs is like a CBME program is 45 days training program. Quality assurance program is 50 hours duration. Now we are upgrading these programs to the postgraduate diploma in the certificate in biomedical engineering, certificate in medical device regulatory affairs. So these programs are full-time programs for the students, and for the working professionals, it will be online programs. It's a 1 year duration. For the students, it will be 3 months or 4 months classroom training, followed with the 7 to 8 months of the internship program. So within this 1 year, the candidate will get the classroom training plus the internship, and followed with the employment opportunities. The results is, till date we trained the more than 2,500 biomedical engineers, students and working professionals both in these multiple programs, certifications and the training programs. And we have the collaborations with almost 100 plus companies and the universities, colleges, MOUs for the collaboration. And it's benefiting to the biomedical industry. Yeah. Thank you. These are the results. Yeah.
Wonderful. Wonderful. Beyond wonderful, actually. So many options, incredible. This is incredible in location, but incredible depth of certification possibilities and training possibilities. I guess I'll move on. You know, what are we going to do after this session? Oh, we're going to a party. Okay. So Brazil, this is a certification of facility services and how it affects healthcare organizations. I think this will be an interesting twist. Ricardo Maranhão is the president of the National Clinical Engineering Society in Brazil, and a great young practitioner. Take it away. ABE-CLIN is the name of their their National Clinical Engineering Society. Uh-oh. This must be Gilvain.
The national methodology of accreditation that is responsible in Brazil for developing and manage the methodology of accreditation. I will present to you the abstracts that I am and Ricardo Maranhão prepared for you in this Congress. The name of the abstract is Certifications for Facility Services and its Impact on Networks of Healthcare Organizations. Ricardo Maranhão, in this moment that we launched the manual sale of qualification, Ricardo Maranhão was a specialist and contribution a lot in the manual and the focus clinical engineer. This manual contains so many different services that provide the services to the health organizations. The organizations need, in the first moment, it must be legally constituted of the state or private in nature. It's important in Brazil on a consider this topic one topic of a criteria of eligibility. And the clinical engineer is contemplating this manual, and we had the opportunity to include the first time in the manual, in the version of the manual is 2020. It's important we consider because in Brazil, the clinical engineering is an important process, and we consider the impact of the clinical engineer in the patient safety. And it's important we develop the people, not only the people that is specialist in clinical engineer, but the people and the professional that is a specialist in the assistance, independent of our characteristics or our category. The objective that we prepared is to present the impact of accreditation for facility services, because we believe that these facility services have a big impact in the organizations of healthcare, mainly in the patient safety. The project of revision of the manual count with specialists and different professionals of the sector of healthcare. All the time when on a revise the manual, review the manual, on a consider specialists to participate in this moment, because on a believe your experience, your competences, knowledges contribute a lot in the manual. First time we analyze the risks that we have, and we analyze the opportunity to include the different and the new services in the manual. In 2020, the clinical engineer is an opportunity to include a new service in this manual. And we collected the information, we did a search, that we have an opportunity to evaluate if it's an import or the impact to include a new service in the manual. The projects involve groups, teamwork groups, and these work groups each work group have a focus in one services. And for example, in the group of a clinical engineer, we had different professionals. And after that, when we discuss the requirements and the standards, we have an opportunity to put in practice, to test in one organization. In the clinical engineer services, we had an opportunity to test in the Orbis. Orbis is one organization in Brazil that have these services, that the focus of its services is clinical engineer, and we had an opportunity to test and to put in practice the standards and requirements, and after that, launched the manual. It's important, the test, because I consider an important phase in the projects. And the timeline of the project consider a test and consider a consult public consultation when the different professionals that have in the organizations of healthcare or the organizations that deliver the services have an opportunity to read, to participate, to give suggestions, or to give and send the critical constructions to the manual, to the standards. If the standard is not clear, the professional have an opportunity to say, or if the professional have an idea to describe the requirement and the standards with a different format, these professionals have an opportunity to send to ONA, and ONA analyze the viability to put in practice or not in the manual. It's important, the projects, because the projects that we used in this moment to launch this manual contribute a lot to have a good manual, a manual with a good structure, and a manual with standards and requirements that's possible to put in practice in the organizations, because it's the main concern that ONA has. We have, when we compare in this moment, the last version of the qualification seal manual is the period 2020 and 2024. There is inclusion these services, and when 3 services we include new services in the manual, hygiene, clinical engineering, and nutrition. And when we compare, we observed 99% increase in requirements between the last version of the manual there is in 2016. And when we compare the version 2016 with the versions 2020. These standards, when we focus operation management, and when we consider, we have a large increase of number of requirements, because we included in the hygiene and clinical engineering and nutrition new requirements. It's different when you consider the leadership requirement and standards, and when you review and adapt it to include the new services, for example. But the operation is a new requirement and new standards, and we increase 97% when we compare the different versions of the manual. And in the leadership, we have a 73% increase of number of requirements. It's a good number too, because the leadership is important. We in this moment we include the governance, quality, system of quality, patient safety, and we connect the impact of the delivery of the service of these organizations in the organizations of healthcare. And it's so important we consider this one. And we conclusion the ONA qualification seal manual involved different services, different professionals, different specialists to constructions this manual. And it's important we eliminate the subjective, we eliminate the duplication, the manual, the requirements or the standards, or we eliminate the interpretation. For example, if you want standards or requirements described in a different logic, is not good. We don't have a good interpretation from the professional and the organizations that deliver a service. And it's important we guarantee and sustainable the standards, the describe of standards and requirements have a good describe and good interpretation for the final user. It's so important. And one important point in the conclusion is we include in this version clinical engineer. And it's interesting because nowadays is the service, when you compare the new service, clinical engineer is the service that have the most increased organizations accredited by ONA qualification seal. It's incredible because in Brazil the culture changed a lot in the last years, and the culture understand it, and the professional in the organization of healthcare understand that it's important involved, for example, a professional of clinical engineer in a committee to patient safety, in a governance when we need to take a decision if we recover or not recover, or change the equipment. And nowadays we have a more consideration and recognize with the clinical engineer in the healthcare. It's so important, and we believe the accreditation in Brazil help a lot to transform this culture when we have an opportunity to explain about the clinical engineer. And the organizations and other professionals understand the importance and the impact of a clinical engineer in patient safety. It's a good results, and we are nowadays so happy about these results, and say thanks for the ABCLIN, because ABCLIN in Brazil is an association that is its focus in engineer clinical. And Ricardo Maranhão is a good specialist that contributes a lot in all versions of the manual, not only in the ONA qualification, but the other manual that ONA has nowadays. And we say thanks for this opportunity to present a little bit for you about the version, the ONA qualification save. And if you would like more information, please don't hesitate in contact me and Ricardo, and we are excited in answer you. Or if you came to Brazil one day, please don't hesitate to. We will have a pleasure to present to you ONA's methodology and ABCLIN. And thank you a lot for your attention. And I am here for your if you need if you have some doubts or other questions. Thank you a lot.
So that's a new, a little bit of a new concept, and I'll make it a little bit clearer that particularly in Brazil, but it could happen in any country of the world where there are outsourced clinical engineering services. They're not an in-house group, but they're a company, and they provide clinical engineering services to many hospitals, perhaps, that they're being accredited. And so this is a manual and a process that oversees how clinical engineering outsourced companies can gain assurance of their skill sets to provide the appropriate services. Next, we're going to call up our friends from India to talk about the equipment maintenance scheme. So please join us. And you're welcome to use the podium or use this mic. Your call.
Slideshow. So good evening, everyone. So myself, Karthik. So I am going to take a scheme related to biomedical maintenance. So the presentation title is Equipment Maintenance Scheme for Enhancing Better Quality in Equipment Maintenance. So when you go to an hospital, you will find equipment will be there. Whether those equipment are in good condition or not, that is the one questions always that comes into mind of a common man. And as a common man, I also feel it. A lot of hospitals are there, which hospital to choose, whether the equipment is properly maintained or not. And there are a lot of questions as a biomedical engineer or a clinical engineer has to ask himself or herself to understand the equipment working. So, next slide. Sorry. So this work is done by following members. So myself, Karthik, and M. Gina, and the most famous person from AMTZ, Dr. Jitendra Kumar Sharma. So there is no need of introduction. And this, not only these three people were involved, there are several back-end people are there, certification committee people, steering committee people, technical committee people. I can see few faces, Mr. Mohan, Mr. Shomashekhar. So it's like a lot of people's efforts were involved to bring this biomedical equipment maintenance scheme. Next slides, please. Okay. So when I go for the introduction part, so the quality, that is the quality of how you maintain the equipment. So what are the criteria for it? So when I say that my equipment is maintained properly, what is the criteria? Show me some objective evidence. So without evidence, we can't say it. Just telling in the thin air that equipment is maintained in a good manner. So that won't be acceptable unless until you show some evidence. So that is a part. The quality of the equipment maintenance for biomedical equipment will define a criteria for how well the equipment can be used without the breakdown event. So as per the WHO, about 50 to 80% of the equipments are non-functional due to a lack of a proper, effective maintenance program. And when I say the maintenance activity is not happening, also there's a competence of the technical expert who is involved to carry out that process also. So if it is not having the effectiveness, then obviously there will be more breakdown, and as a result, the hospital, whoever using or purchasing the equipment, they won't be getting the benefit out of it. So proper maintenance and the proper use of medical equipment, which are very, very critical aspects. So if you know how to maintain the equipment, and the person who is using the equipment should know how to use the equipment. If you know these two things are done properly, the most of equipment failure you can avoid it. So always the biomedical equipment maintenance presents a challenge for many of the countries, low income countries. And so we started, so I can proudly say that AMTZ, so with the help of IMED and AHPI, so the first, globally the first biomedical scheme, that is biomedical equipment maintenance certification scheme, which is based on the ISO 17065 standard. So when I say ISO 17065, so the global acceptability will be coming into picture. So ISO 17065 means product certification. So under product certification, we do have three things are there in the standard. Product as itself, or process, or service. So since we are going for the maintenance activity, it is a process domain. So the maintenance process, that is what we are checking it. Whether they are doing, the hospital or a clinical or maybe a AMC-CMC provider, their maintenance process is they are doing it properly or not. And it will be validated by a competent person who has already having a biomedical experience. So all are defined in the scheme. So, and also there is IAF, that is International Accreditation Forum, MD 25 document, that is the scheme requirements. When you develop a scheme, what are the requirements for the scheme? And also one more standard is there, that is ISO 17067, which will, it's a guideline kind of a thing, which gives the product certification scheme what is the guidelines. So these three standards are taken. So the primary purpose of this scheme, as I said, so once an equipment, when you purchase it, and once it's going to a clinic or whether it is going to an hospital or anywhere, let's say that it is going to a home, in your home itself. Now whether, once the installation is done, now when I'm using it, I should get a feel that the equipment is in good condition or not. Unless or until I don't feel it, whether it is in good condition, there is no point. So you are trying to say that the equipment is maintained properly. So now it can be after installation, I do servicing and repair. Once this activity is done, we are making sure that the equipment is in good condition. So now how I will say that it is in good condition, that is what the scheme is defining it. And this can be implemented by a hospital. So they will have a biomedical department or clinical engineering department which can take up and this scheme guidelines and they can put it, or a AMC-CMC maintenance provider. So third party maintenance provider who will go and do the servicing activity in the hospital or a clinic, or even the original equipment manufacturer. So Siemens or Trivitron, anyone can use this scheme. Now the process, I said it's a maintenance process. So even if ISO 17065, it's a product certification. Under product certification, you have three things. I said process, service, and product. So here we are going for process. So you can see that once the maintenance, so how we are telling it in a flow chart, I have shown it. So first activity is that you have to choose the equipment, where it belongs. So there are four equipment category we have taken it, that is non-active medical device. Then we do have active medical device, non-implantable. Then IVD instruments. Then sterilization method for medical devices. So this we have taken from the IAF MD9 document. So International Accreditation Forum, MD means not medical device, it's a mandatory document, 9. From that only we have taken this category. And again, I want to say that the scheme is not applicable for few things, that is implantable medical device, we are not applicable. Then single-use disposable medical devices, not applicable. Then software-based medical devices, that is fully software. I'm not saying hardware-software combination. Fully software-based medical devices are also not applicable for this scheme. Other than these three, everything is applicable. So that is the 4 main categories. Now, first, once you put the equipment in any of these 4 categories, now we have to see that whether the equipment is powered or not, whether it is connected to the power supply or not. If it is connected to the power supply, then you have to check the electrical safety. Okay, so electrical safety, whether it is good or not. Again, you do have standards, various standards are there. Actually, the best standard is IEC 62353 standard. What this standard says that it defines the basic requirements for the electrical safety testing for any medical electrical equipment and systems during routine intervals. So when I'm doing the maintenance process, the leakage current, what is the minimum level, whether it is within the minimum level or not. If it is more than the minimum level, obviously there is a chance for micro shock and macro shock for the patient. So the patient, the doctor may say that the patient is died, but it can be because of the equipment malfunction, the patient might have died. So there are a lot of points that perform the electrical safety testing, depending upon which you use it. And I said one more is that is IEC 6001-1 standard. This will be used by the manufacturer. When you are installed the equipment in the hospital, we don't try to follow the IEC 6001-1 standard. Why? Because it will reduce the lifetime of the medical equipment. So as a biomedical engineer or a clinical engineer who is working in a hospital, they can put like a criteria, acceptance criteria. So when I say acceptance criteria, that once you buy an equipment and if it is connected to the power supply, you tell him to issue the IEC 6001-1 report, or you do it with a date, confirmation date that you have recently done it and it is following as per the standard, everything is done correctly. So that you can put an acceptance criteria. Once you accept the equipment in the hospital, no need to follow the IEC 6001-1 testing because it will reduce the lifetime of the equipment. So it's better to use the IEC 62353 standard, and that is what perform electrical safety. Then suppose if the equipment is not connected to the power supply, then directly you can move to the next step, that is perform the maintenance as per 2 checklists. So I will tell you in detail with an example. So because we do have lot of medical equipment, it's not like 100 or it's more than 3,000 equipments are there, and it is a very vast list. Okay, so I've just taken one small example and show you what is the checklist. So there are mainly 2 checklists are there, common checklist and scheme product category checklist. So I'll tell you what is this common checklist and scheme product category checklist in the upcoming slides. So this is the concept of checklist. So each category, so category means you have 4 categories are there, that is your non-active medical devices, then active medical devices, non-implantable, then sterilization method for medical devices, then you do have IVD instruments. These are the categories. Now each category you do have subcategory. Now each subcategory you do have scheme product category. So I will tell you what is this subcategory, scheme product category. Now here the point to be noted is that each category, the 4 main categories will have a checklist. That is non-active medical medical devices will have a checklist. Then sterilization method for medical devices will have a checklist. Now this is followed by, it will be subdivided into different domain. So this is again as per the IAF MD9 document, so that it can be globally implemented. Once the subcategory, so again subcategory is divided into scheme product category, and each scheme product category will have a checklist. Now, what is this checklist part? I will confirm with this example. So the main category I've selected is the active medical device, non-implantable, and it's having subcategory. These are the following subcategories which we'll call in the scheme as technical areas. So under that, I have circled one, monitoring devices. That is the example I'm going to talk about it. So if you take the monitoring devices, that is a subcategory. Now it is again divided into, you do have scheme product category. So again, you do have 2 scheme product category under monitoring devices. That is one for physiological, vital physiological parameters and non-vital physiological parameters. The first one is the monitoring devices for non-vital physiological parameters, and second one is the monitoring devices for vital physiological parameters. What examples I have shown it, there are several examples are there. Only just for understanding point of view, I've given one example. Now I'm going to take the monitoring devices of vital physiological parameters to show you what is this general checklist and the scheme product category checklist. So this is the general checklist or the common checklist for the your active medical devices, non-implantable. Now you do have following points. So I'll tell you the first point, that is chassis verify the physical integrity, cleanliness and condition. So in the next column you will see that whether it is acceptable or not acceptable or not applicable. Now you can write the scheme, because we are not going to focus equipment wise, we are focusing as a category. So in that category you will have more than 100 equipments will be there. So that is why you are putting so generic so that it is applicable. So devices for respiratory devices will be there. Then active surgical devices will be there. Then devices for imaging. So when I say devices for imaging, obviously whether I'm using non-ionizing radiation or ionizing radiation, then again devices for imaging can again go for therapy also. So where again devices for therapy can be again ionizing or non-ionizing. So a lot of divisions will be there. So under that, this is the main checklist. So you will be writing it, and there are points are there. So you can see it, more than 23 points, checkpoints are there. I say this is the minimum. Okay, so you can always enhance the checklist. So for the scheme requirement, this is the minimum checklist you have to maintain for this equipment that is belonging to the active medical device, non-implantable. And some of the checkpoints, you can see that a star symbol will be there, superscript, star symbol will be there. That is showing that you have to do it as per the manufacturer-defined guidelines. So when you say calibrate electrical equipments or electrical components, you have to do it as per the manufacturer specified in the either in the service manual or you get it from the manufacturer. What are the calibrating electrical components that is available for this equipment, you have to get it. Now this is the general checklist. Now we are going for the scheme checklist. So before going, you can see a note, I have written it. All tests shall conform to the IEC 62353 test report. So if it is an active device, if you are confirming it, you have to accompany this test report, which will have the leakage current, all the values, and you can make sure that the equipment is maintained in a good manner so that there is no chance for this micro shock and macro shock to happen for the subject. And also we have to define the grounding of the hospital is maintained in a proper condition. That is another clause you have to keep it in the mind. Now the scheme product category. So general checklist is, that is common checklist, then followed by your scheme product category checklist. So which I have taken as the monitoring devices for, that is vital physiological parameters. So you can see the first point, check all the leads and cables. Ensure that the cables are not twisted. This is a very simple thing. You take a multimeter, check the continuity, and when you check the continuity, you have to measure the resistance value also, whether it is within the limit of that lead. Otherwise, the cable may give the continuity. Maybe within 1 week, the cable can be broken because the resistance value was high. So you have to make it that you observe what is the resistance value that is shown in the multimeter. And also you have to take into account the multimeter error. Lot of factors when you check it. So a person who is checking the process, again, he or she should be having a hospital biomedical experience, or maybe in the regulatory sector, or maybe in the R&D, so that the checking process will be effective. That is the major part, which is also defined in the scheme requirements. So this is the scheme product category checklist, which again, we do have 14 points are there. So this is what I was telling in the concept of the checklist. So if you go back here, so I said each category will have a general checklist. Then you do have subcategory. Then each subcategory will have the scheme product category. And the scheme product category will have the checklist. So the entire document is available in the net, so that if anyone want to implement it, effective maintenance part, you can use it. And I always say that this is the minimum requirement. Always you can put more points into the checklist part, depending upon the requirement of your hospital. Sometimes the equipment will be old. Sometimes the defibrillator machine that you are maintaining in a 50-bedded hospital is only one. So in that time, the maintenance activity, this frequency will be changing. So the scheme mainly it is intended to significantly reduce or eliminate the maintenance breakdown in hospitals and improve patient safety, quality, and performance of the medical equipment. So whoever the equipment using it, so the patients would be safe as well as the equipment end user should be also safe. So this scheme is applicable for all medical devices except I already said implantable medical device, single-use or disposable medical devices, then software-based medical devices. Fully software-based medical devices, it is not applicable. And the link below, if you click it, you will get the relevant documents which are talking about the scheme and how to implement it. So as of now, we have provisionally approved 4 certification body to whom will be getting. That is, suppose if you are a hospital or a clinic, you want to get for this scheme, there are certification body will be there, which we have, AMTZ have provisionally given the approval. And those certification body will only certify your premise, saying that you are maintaining the equipment maintenance process as per the biomedical equipment maintenance certification program. So this is globally one of the first such scheme which talks about the maintenance activity. So that's it, my mail ID. So if any doubts regarding the scheme, you can always contact me through this mail ID. So thank you. So if any doubts, clarification, I'm here.
We have a moment for questions. I have a question, maybe others will. So has this been applied? I know, for instance, Dr. Sharma was talking about you have certain hospitals that have acquired your services in a variety of ways. So has this scheme been applied, and what are can you talk about results?
Yes, yes. So the process is, I already said, first we have to certify this certification body. So AMTZ has provisionally given 4 certification body, we have approved it. Now, there are scheme requirements. So when I go to an hospital, in the scheme requirement, I have given minimum checklist. So they have to maintain this minimum checklist and they have to keep record, evidence record should be there. So we are given a period of 30, that is 3 months, so that means 90 days. So they have the record implementation, and the certification body, when they go for checking whether the maintenance process is active on for a particular hospital, they will check the record as well as the planned preventive maintenance activity. So the certification body, when they assign the team, so the audit team will consist of auditors as well as technical expert. So technical expert mainly having the biomedical experience. So that way, so one that is third-party maintenance provider, Sodosco, so they are implementing it. So they have done the checklist. Now they are putting the checklist in their software so that whenever they do the maintenance activity, the minimum points, whatever we have defined it, that will be, they will be checking it. And most probably January, we will be having the audit section.
So that sounds like what we heard just previously from Brazil, where they're these outsourced
Yes, that is
services.
one kind. And hospital, so Apollo Hospital, so they do have maintenance
from the
agency.
inside.
Yes, in their inside itself, Faber Sinduri. So they are also in practice, they are implementing this checklist.
So maybe another scenario is then when AMTZ, a subset, a company of AMTZ provides the service to the hospitals, because that's also...
No. I'm not providing the service. What?
But I thought another arm of AMTZ,
so,
though, might be providing service to hospitals.
Actually,
not true, okay.
Maintenance process, I'm making it. Right. I am the scheme owner. Yes. So I am just putting a certification body. You are provisionally certified to go and check the maintenance process.
Okay.
Because there is a conflict of interest will come,
I understand.
impartiality.
Are there other questions from the audience? What?
Yeah.
Thank you. Nice presentation. And I just want to know if there is the recording system or everything is on manual, so that I want to...
proof. That is, if you say that IEC 62353, you have said that the minimum requirements have met, you have to show the report. So one example sample, it's always auditing when we go for it. The audit team goes, it's a sampling process. So let's say that you have in your hospital 1,000 equipments are there. Under the 1,000 equipments, they do have sampling criteria will be defined. The 1,000 will be cut short into 100. Under 100, they will check few records and they will see the maintenance activity, ongoing maintenance activity, how you are doing as per the checklist. So that will be taken care by the technical expert.
So it's for the auditor purpose also, and it's not going to be recorded somewhere in software or something.
It's up to you. You can even use software, fine. Because that is what Sodasco, what they have done is that they implemented the checklist. The checklist is available in the website. So that is Annexure 4 technical criteria. So Annexure 4 talks about the checklist. So almost scheme product category, 36 scheme product category is there. So each is having checklist plus your 4 main general checklists. So they are implementing in their software. So when their biomedical engineer or clinical engineer goes to the hospital, they will take the printout of that checklist and they will do the maintenance process as per the checklist. It has to be recorded. So they have to get it signed from the hospital side and the seal, and they have to record the time also. So in the software, it is already inbuilt.
And does it record the values that while like calibration?
Yes, that is remarks.
Okay, thank you. Thank you so much.
Other questions? If not, we'll go to the last presentation from Jim Weir, and thank you so much, Karthik. I think we have one other question from Bangladesh.
Sir, I have a question to you, basically. That's why presenter not required.
Bring it on.
So, sir, already I have seen a lot of presentation here because of this is my first attend in ICEHTMC. More or less, all presentations come out, the maintenance period, maintenance team, how the preventive maintenance schedule and how to reduce the breakdown maintenance or corrective maintenance, like that all over the, all presenters like that talking about it. My question is, IFMB or GCAA have any plan to make a guideline for the medical equipment maintenance guideline, like that industrial applications, some have ISO or IEEE have a guideline for industrial machineries maintenance. So IFMB have any plan to maintenance guideline?
If I understand the question, and I think I do, we would probably point to what Adriana was presenting this morning in the Medevis system and all the guidelines books that goes with the WHO guidelines that many of us around the world contributed to. So the answer is no, CED and GCA are not creating more schemes. We're pointing to the schemes that were already developed through WHO.
Okay.
Can you live with that answer, and can we move on?
Okay, thank you.
All right, thank you.
Thank you.
So Dr. Jim Weir, who is a young, I think about 87 years old, but still volunteering here around the world. So we're going to hear from Dr. Weir and close this session and get ready to go to the party. So
okay.
Let's go.
Just I'm asking, especially medical equipment is different comparatively industrial machineries. So guidelines plus others regulations will be different according to industrial machinery. So
check out the WHO guidelines and then ask me the question. all the stuff on the WHO medical device unit for Madriana. Take a look at that.
Okay, okay. Thank you.
Thank you.
Thank you so much.
Dr. Weir. Does Dr. Weir not have audio? Because I can talk about it if it's... Can you show the PowerPoint? If he just has the PowerPoint and I'm going to talk about it audio, before that, Remy, come on up. Remy, do you want to talk about the gala for a moment? Okay. We're getting closer.
Okay, so before we start, so we have time, so just wanted to inform everyone, today we have a gala dinner in the city in one of the hotels, the park, and you all have got your passes for that. So requesting you that we will move to the venue right from here. We are not going to hotel or your hotel where you're staying. We will straight away go to the venue, that is the park from here. So if you want to change, you can change here or you can go there and we can change, and we'll be reaching the venue in 1 hour or maybe 90 minutes.
So the shuttles will depart from the front of the building about beginning what time?
Yes, so as soon as we finish here, which is I'm expecting by 5:30.
5:30?
Yeah, so I'm expecting if the session gets over at 5:30, we leave by 5:45 from here. The buses will be waiting outside. I think as soon as we finish, in all the halls, we will leave from here straight away. And all the 3 buses will be waiting outside. So you can take any of the bus because all the buses will head to the park.
Are we expected to have any fun?
Of course, yes. That's a surprise.
Okay.
Yes.
No, we're going to have great fun.
Yes. And do look your best. Thank you.
Thank you. Okay. You're going to have a link to this presentation, and really a lot of the concepts have been presented today, so I know it may break your heart, but we're going to end the session right now. And thank you for your time. In other words, we're done.